So, good afternoon to all dignitaries, guests, and delegates. With great joy and immense pleasure, I feel privileged to extend my warm welcome to all presented here for Symposium 2 on multimodal approach to cardiovascular function assessment. Now I invite our chairperson of the symposium to please come on the stage, that is Dr. Aarti Sood Mahajan. She is presently Director Professor in Department of Physiology at Maulana Azad Medical College. She had 31 years of experience and has contributed a lot to medical education, from being an honorary member in the medical education department since August 2003 to being a resource faculty person at numerous workshops. Dr. Atisud Mahajan has been awarded with GSMC FAIMR MER Regional Institute Fellowship. Her key area of research is in medical education. She has also worked on yoga research, infertility, evoked potential, OSPE in undergraduate teaching, and many more. She has published 28 articles, 2 chapters in a book, and 1 book on medical education. Not only this, but she had been an active member of the editorial team of Sankaran and reviewer for many journals. Dr. Aati Sood Mahajan, I would like to invite you to please introduce our speakers. Please.
Thank you so much, everyone, for being here. I'm delighted to come here to Faridabad, my first experience here. And I will be introducing the speakers. I hope all of them are here. Huh? So, the order that is written is Dr. Shrival Srivastav. Are we following that order? Okay. So, I will just introduce the speaker. Dr. Shrival Srivastav. He is an assistant professor of physiology as well as the Dean Academics of All India Institute of Medical Sciences, Jodhpur. A wonderful place to be in. Yes. Being a member of Vascular and Autonomic Function Lab at AIIMS, New Delhi, during his MD, Dr. Shrival has taken keen interest in evaluation of the vascular and autonomic function. He has several research articles in this field and has also co-authored a book chapter on assessment of arterial stiffness. He will be talking today on assessment of baroreflex sensitivity techniques and clinical relevance. Please come. So,
cardiovascular function assessment. So we all know that cardiovascular diseases remain the key cause of global morbidity and mortality, and it is one of the commonest cause of death in elderly patients and even now in the younger population. It remains a well-known fact that early diagnosis of cardiovascular disorders is the key, and a lot of emphasis is being laid upon whether we can catch the population who is at risk young, and we can take in, say, interventions such as lifestyle modification, dietary and other changes, so as to, say, reduce the future risk of disease and future risk of mortality. And herein comes the clear role of our colleagues from the branch of physiology, wherein we can play an instrumental role in the evaluation and assessment of cardiovascular function. I'm sorry, just give me a minute, please. So we can play an important role in the cardiovascular assessment, and therefore we can help the clinicians in identifying the at-risk population, and therefore just help them screen in the early risk of cardiovascular disease. Now it goes without saying that such an approach to catch the people who are at risk of cardiovascular disease needs to be multimodal rather than a single modality. Therefore, in order to adapt this modality, we need to say evaluate multiple parameters such as the assessment of the baroreflex function. Then we need to talk about the vascular function, and then we also need to see the transcranial Doppler, and of course other modalities also exist. So in today's symposia, we will be focusing on three key constraints of this methodology, wherein I'll be talking about the first part, wherein we'll be talking about the assessment of the baroreflex sensitivity, what are the techniques available, and what is the clinical relevance of this assessment. Then secondly, my colleague Dr. Manpreet ma'am will be talking about the vascular health assessment using arterial stiffness, the principles and the recent advances therein. And finally, my colleague Dr. Kiran Prakash madam will be talking about the role of transcranial USG to assess the function of the cerebrovascular function and assess autoregulation in these. So starting with my talk, so we all know from our undergraduate and postgraduate knowledge that the baroreflex plays a key role in beat-to-beat regulation of the BP, and it is an important mechanism for short-term regulation of BP. This diagram shows the overall structure of the baroreflex mechanism. We know that the receptors are located in the arch of aorta and in the carotid sinus. From therein, they are carrying their efferent impulses via the 9th and the 10th cranial nerve, and these impulses are being relayed to the nucleus of tractus solitarius, which is the integrating center of this information. Now, nucleus of tractus solitarius relays this information to two centers. One is the vagal nuclei, which is the nucleus ambiguous, and which is giving out the 10th cranial nerve, and the other output is going via the RVLM and the CVLM centers in the medulla, which is going to the intermediolateral column of the sympathetic ganglion, and therefore giving out the sympathetic postganglionic fibers. So in these sympathetic efferents that are originating from the sympathetic ganglion, which are located on either side of the lumbar pathway, so these fibers are innervating our cardiovascular system in the heart, where they are responsible for regulation of the cardiac output and the stroke volume. And these fibers are also going to the sympathetic via means of the sympathetic ganglion fibers to the vascular system, wherein they are responsible for regulation of the peripheral resistance and therefore have a role in regulation of diastolic blood pressure. So the next question that should come to our mind is why assess the baroreflex sensitivity or BRS function in the first place. So it is a well-established fact, if I may say, it is a textbook fact now, that impairment of the BRS or the baroreflex sensitivity is shown as a prognostic factor in multiple diseases such as heart failure, myocardial infarction, then arrhythmias, chronic kidney disease, and essential hypertension. It has been shown that if we are able to assess BRS, we may actually get early clues regarding these disorders, and impairment of this parameter, baroreflex sensitivity, can give us a clue regarding the future risk of adverse events and the future risk of morbidity and mortality. So the initial work regarding BRS assessment was first performed in 1984 and 1988 by Schwartz and colleagues, wherein they were experimenting in a canine model, and they were actually trying to create a model of myocardial infarction. In this model, they wanted to investigate the sudden cardiac death, and they produced coronary occlusion to create an MI model. And in their preliminary findings, they found that 30 days post MI, in the subgroup having anterior wall MI, they assessed baroreflex sensitivity by a drug that is known as phenylephrine, an alpha agonist, and they were able to find the fact that reduced BRS that was noted in this group was associated with an increased incidence of MI. So it was the first study that showed that myocardial infarction is reducing the baroreflex sensitivity, and in the subsequent studies, they found out that in the post-MI group, the animals which were there, when they subjected them to exercise stress test, they found that these animals were exposed to the increased risk of ventricular fibrillation. Also, interesting finding was that in the subgroup that had normal or increased BRS, this risk of adverse cardiovascular event was not seen, and this finding helped them establish the fact that baroreflex sensitivity may be used as a prognostic marker for adverse cardiovascular event. So, in this studies of the early 1980s, the emergence of BRS as a parameter was seen, and it was shown that BRS can be seen in disorders of the cardiovascular system, and it can also help in the prognostication part. Going on from there, how we can assess the function of the baroreflex? This can be done by the assessment of the blood pressure signals and the ECG signals, and this assessment can be done at rest or can be done using provocative measures wherein we can produce changes in BP. At rest, assessment of baroreflex function is done by something that is known as sequence method, which I will be discussing in a short while. And provocative measures, as the name suggests, they are used to produce perturbations in BP, which can be done by pharmacological or non-pharmacological method. And the resultant changes in BP and the compensatory changes in heart rate can be used to assess the baroreflex function. I have some experience in working with the sequence method and Valsalva maneuver and lower body negative pressure and HUT. So these are the parts I will be focusing upon. So to start with, what do we require for the assessment of the BRS? The two key signals that are required for BRS assessment are continuous beat-to-beat BP. This continuous beat-to-beat BP can be assessed by using invasive methods if we are using an animal model. Even in human studies, I have again come across in conversations with my colleagues from anesthesia, there are many surgeries where they put in arterial line, and what they are doing is they are recording continuous BP as a parameter. Then the other signal that we require is heart rate or the RR interval. This can be acquired using a lead to ECG signal. In addition to these two signals, continuous beat-to-beat BP and lead to ECG, it is also advisable to have a respiration signal. This is commonly done in the physiology laboratory by using a digital stethograph. Now, starting with the first method, that is identifying this method at rest, which is talking about the sequence method. So, as the name implies, what we are looking at is we are looking for sequences of changes in blood pressure at rest without any perturbation, and these changes or fluctuations in blood pressure should be accompanied by corresponding changes in heart rate or the RR interval. Now, identification of sequences which is done is defined on multiple criteria. For example, we need to take into account first is the lag part, that is after how much the interval of the change in BP, whether there is a rise or a fall, there is change in the RR interval. So that lag again in literature has been defined from say a lag of 1 beat, which is commonly used. In some models even a lag of 10 to 12 beats has also been proposed, but for most of our common calculations we use a 1 beat delay lag in this calculation. Then the second part for identification of the sequence is that how long the sequence should be, whether we should take 1 beat, 2 beat, 3 beat, 10 beats, etc. So this also needs to be taken into account. Now, when we talk about a sequence, what should be the delta or the change in BP and the corresponding change in RI interval, and whether there exists a baroreflex mediated relationship between parameters number 3 and 4 that can be assessed by a parameter that is known as coherence. So this is how it goes. See, is a representative recording of a healthy subject taken in from at Autonomic Function Lab, New Delhi, wherein in the upper panel we can show, we can see the RI intervals which are expressed in millisecond, ranging in something like 600 to 800 milliseconds here. And then in the lower panel, this red color thing, I think it's visible, red colored tracing is showing the systolic BP. Then we have the mean and the diastolic BP tracings. A continuous record of almost 300 seconds if you can see, that is 5-minute recording is required. Now, once this signal has been acquired and we have the BP signals and the RI interval signals, then it goes about the software mediated identification of the different sequences. This is done by identification of up and down sequences. These are identified by criteria listed on the right side of this panel, wherein the software says that RRI interval variation greater than 5 milliseconds should be taken into account. Then a BP change greater than 0.5 mmHg should be able to engage the baroreflex and therefore produce a change in the RI interval. Also, the length of the sequences that is recommended should be 3 beats or longer, and there should be a strong correlation between these two parameters, that the BP changes are responsible for the change in the RI intervals, and therefore there should be a good handshake or a good coherence between the signals, and therefore we take the correlation coefficient that is derived as 0.85. And of course, as I said previously, that the lag, that is the delay between the BP change and the corresponding change in the RI interval is 1 beat. I'll again emphasize that these parameters are user defined and we go by what is mentioned in literature. But if experimental paradigms are changing or we want to modify these criteria, we can modify and look upon these sequences. So after identification, this is the representative result of the subject in question. So we can see that we have been able to identify the up sequences, the down sequences, and all up and down sequences for systolic BP, mean BP, and diastolic BP. The number of sequences in up and down is coming out around to be 12, and the all BRS is coming in the range of 13.7. So again, from this information, we can imply that baroreflex sensitivity assessment can be done for systolic blood pressure changes, mean BP and diastolic BP. All three have been reported in literature. Most consistently, we take SBP versus RRI. These are the sequences we take into account, and we take a sum of both all the up and the down sequences, and we are all focusing on the all BRS part of the result. Then the second part of this relationship between the perturbations in BP and the RI intervals at rest is done by another mathematical approach which takes into a spectral analysis approach. In this, the assumption is that the spontaneous oscillations that are taking in BP and that is leading to a change in the RI interval can be centered around two frequencies, the low frequency and the high frequency band. And there is a mathematical technique, that is autoregressive method, which takes the square root of the ratio between the RRI and the systolic BP spectral component, and alpha LF and alpha HF2 indices can be done. Again, since this spectral analysis is mathematical, so it goes without saying that the relationship between two signals should be strong, that is the change should be baroreflex mediated, and therefore we require a good coherence between the signal, before we can approach and interpret the spectral values. Then the second part of the BRS assessment is done using provocative maneuvers which produce a change in blood pressure leading to a change in heart rate. This is a classical maneuver done at bedside in the autonomic lab. We also use it for teaching UG students, that is Valsalva maneuver. In Valsalva maneuver, we ask the subject to perform forced exhalation against a closed glottis in daily life. In the lab, when we want to quantify this level of exhalation, we perform it against an open glottis but into a closed system, wherein we connect the subject to a mercury or an aneroid sphygmomanometer. The standard pressure for Valsalva maneuver comes out to be around 40 millimeters mercury for 15 seconds, that is the recommendation. And based upon the hemodynamic response that is seen in the top panel of this graph, the maneuver can be divided into 4 phases. Phase 1, the initial upstroke in the BP, which is primarily mechanical. Phase 2, which shows a S-shaped relationship, a dip in the systolic BP followed by a recovery. Then phase 3, which is just talking about the momentary release of pressure, again a mechanical event. And phase 4, which is an overshoot. So while phase 1 and 3 are purely mechanical, phase 2 and 4 are what are leading to wherein the baroreflex is coming into play. And here the BRS assessment is done by the identification of phase 2 and phase 4. Again, the parameters we require are the RI intervals and the systolic BP values. So we need to visually identify the phase 2, for example, identify the tracings, the SBP values and the corresponding changes in the RI interval, plot them. Another approach will be to take phase 4 of the maneuver, wherein again we will identify the peak SBP values, followed by which we need to plot a regression curve between the RI intervals and the SBP values. So a linear regression is performed between the RI intervals and the systolic BP values, and the slope of this linear regression, which is shown in purple colored in this diagram, coming out to be around 4.598, it gives us a measure of the baroreflex sensitivity. For Valsalva maneuver, I came across literature, multiple values have been reported wherein they have taken both phase 2 and phase 4, and the values come in the range of something like 3 to 5 millisecond per millimeter of mercury. In another approach in this could be the assessment of BRS using lower body negative pressure. In lower body negative pressure, we create a suction at the level of the iliac crest and create negative pressure on the lower half of the body. This leads to pulling of blood in the capacitance vessels in the limb and therefore reduces the preload on the heart. So again, as seen, we can see these two dotted lines, which is the duration of the LBNP suction. So during the phase of suction which is applied here, we can see that there is a dip in BP. As soon as the suction is released, we can see by this again blue line, it is showing a recovery. So the fall in BP and the recovery phase of the LBNP can also be used for BRS assessment. Now, while these two techniques, lower body negative pressure and LBNP, are both operating by means of reduction in preload, they are mechanistically not similar. This is because Valsalva maneuver is an active effort by the patient wherein he is engaging in the intrathoracic pressure because of creating an active exhalation, where lower body negative pressure is more of a mechanical section, a passive suction. Also, that active effort which is taking place by the part of the patient increases the, I may say, the involvement of the central command. Also, it can lead to the engagement of the pulmonary stretch receptor. So, if we contrast this BP trace with the previous diagram, we can see that the Valsalva maneuver, the tracing follow a typical wavy pattern, S-shaped pattern, where in the short burst of LBNP which is there, the fall is more gradual. So this is what I evaluated as a part of my work, wherein I compared the baroreflex responses to Valsalva maneuver in LBNP, and we came across a paper that said that both these maneuvers are interchangeable and they can be used in place of each other. However, while one was a passive suction and other was an active maneuver, so this question came to our mind that they should be dissimilar. So we recruited 22 healthy male volunteers with a mean age of around 26 years, and we asked them to perform Valsalva maneuver and lower body negative pressure. So both maneuvers were performed for 15 seconds to keep them comparable on a temporal time scale, and the pressures were also similar. We acquired continuous beat-to-beat blood pressure and lead to ECG signals. And again, as shown previously, we plotted a regression curve between the downstroke and the upstroke phases and calculated the BRS values. And BRS value calculation was done using phase 2 and 4 of Valsalva maneuver. For LBNP, we found out that no paper had earlier used LBNP to calculate BRS. So similar to phase 2 and phase 4 of Valsalva maneuver, we chose the during suction part and the post suction part of LBNP, the slow part, and we plotted the BRS. Now the results are interesting. While the BRS values for LBNP and Valsalva maneuver were statistically comparable, that is, there was no significant difference between the BRS parameters. However, when we studied the bias between the values using blind-Altman analysis, we found out that there was significant bias between the two parameters. So this contradicted the previous notion that these maneuvers are interchangeable, and we found out that these should not be used interchangeably for the assessment of BRS because they are both mechanistically non-similar from a point of view of performance. So the reason we deduced that Valsalva is probably effort intensive, engaging the central command, the pulmonary stretch receptors, and it is requiring active patient participation, whereas lower body negative pressure is just passive suction on lower half of the body, and therefore both these maneuvers were not interchangeable when it came to assessment of BRS. Then another interesting finding what I came across was that since there are multiple protocols, softwares and techniques available for the assessment of BRS, this question came to the mind of Lodge and other colleagues, wherein they recorded the beat-to-beat BP signals in 21 subjects, including 2 subjects with baroreflex failure, and they compared these analyses that could be done by different modalities across 11 centers. Comparison of BRS was done using different parameters such as the data length, overlap, the choice of the frequency bands, etc., and interclass correlation coefficient and coefficient of variance was compared. They came across interesting finding that transfer function or spectral component and sequence method showed a very good agreement. Mean BP values when used to calculate BRS showed a poor agreement, and they recommended you should not use MVP BRS. They also said that if the whole segment of the BRS, whole data segment is recorded, the reproducibility and the reliability of the values is high, and correlation coefficient and lag parameters did not have much effect on the BRS. Then again, to wind up the last part of my talk, how should we perform baroreflex sensitivity assessment in the lab? Are there any standard guidelines? The answer is yes. In 2011, Toronto Diabetic Neuropathic Expert Group, they formed a subcommittee for cardiac autonomic neuropathy, and they gave these guidelines that they wanted to assess BRS assessment rating it by the quality of evidence and the strength of recommendations. and the methodology that they used was validated by American Academy of Neurology. What they proposed, their findings, their recommendations highlighted that BRS is an independent prognostic factor for cardiovascular disease. Number two, no definite conclusion is possible on the diagnostic characteristics. Use of BRS is very useful for identifying the subjects at risk for cardiac autonomic neuropathy and to do drug trials and other therapeutic approaches. And none of the BRS as a parameter that we have shown a definite benefit over other parameters. So they are inherently, we can choose with any one parameter and go ahead with performing the analysis part. Then the recommendations proposed were that recording should be done under a controlled breathing environment, that is around 15 minutes, 15 breaths per minute for 5 minutes. Then the recording time should be something like 4 to 5 minutes. Longer time frame with uncontrolled breathing should be avoided. Pre-filtering of data led to better values, and subject should not speak during the recording, lie still, and every lab that is say targeting to report BRS should have their own normative data set to have the 95% confidence interval. The drift of the BP equipments, slow breathing, verbalization during recording, age-related changes, and calculation-based software-imposed constraints are confounding factors and should be taken care of when we are reporting BRS. So with this, I summarize my talk. We have discussed that BRS is an important predictor of cardiovascular disease for morbidity and mortality. It can be easily evaluated in the lab if we have continuous BP, RR intervals, and respiratory data. It can give us both prognostic and diagnostic information. And herein comes our role as physiologists, wherein we can generate normograms for our own population. We can evaluate these parameters in different diseases, and we need to engage, put in our efforts into doing cohort studies or long-term follow-up studies to see the prognostic value of this parameter. So with this, I acknowledge Professor Deepak, Professor Jaryal sir, Dr. Dinu sir at Autonomic Lab, AIIMS, New Delhi. My faculty members, Dr. Omlata ma'am from AFT Lab, AIIMS, Jodhpur. Late Professor Rajesh Kumar Sharma sir, who established this lab at AIIMS, Jodhpur. And also I express my thanks for APPI and ESI to provide this forum to share our views. Thank you so much.
Thank you, Dr. Srivastava. Should I ask questions now or at the end of all three? Right now. I think this was a wonderful presentation and belonging to Dr. Deepak's lab, I think. Yeah. So you are one of the best people to talk about it. Yeah. One thing, you have talked about the 3 tests that you feel. One of the thing is that they are prognostic, in your opinion. Secondly, you feel that the 3 are not so much dependent on each other. They are independent and should be independently done also. So you do not propose any one test to be better than the other. That's what I've gathered.
Yes, ma'am.
And so I would just like to ask you one thing is, first of all, can you give us, because you are belonging to this lab, approximate number of tests that you have done for all the 3 so that we get an idea of how many you have done total, like in your, when you were there approximately?
Ma'am, sequence method, actually I have been part of 2 or 3 projects where sequence methods have been done, each running into numbers of something like 30 to 50 patients. Okay. So for sequence method, what I have personally analyzed is something like data of almost, if I remember correctly, 150 to 200 patients. Okay. And for LBNP and BRS, that was part of my thesis work. So therein the number was on the lower side. We had 30 subjects. So therein we have done for a small subgroup only. Okay. So this is, but again, data of sequence method, India, ma'am, multiple centers are reporting now, and they are generating their own normograms. So ma'am, data is available regarding that now.
Yeah. So roughly, you must have crossed the 1,000 limit in your lab as such. I'm sure much more than that, you know.
Maybe well beyond 1,000, ma'am, maybe.
Yeah, because definitely you are one person who's working. The other people also would be working.
My colleagues sitting here, they have healthy controls
where
they're there.
Yes, I can understand.
So the data of large population cohort is available, ma'am.
Yes. So at one time we were hearing that you were going to have a database for the Indian population. So is that in pipeline?
Ma'am, it would be actually, again, we should have a center-specific data because of the regional variation in the population. So, ma'am, Delhi may at the department, there is data set that is available for the sequence methods and other. Again,
Okay.
compilation part and putting that in public domain we are in the process of
Yes, that's
doing
what I
that.
had heard,
Yes, ma'am.
because that would be very useful not
ma'am.
only for you, for everybody else.
Yes, ma'am.
While you
Yes,
may standardize, everybody may standardize their own lab,
Yes,
but once there is a data available, it is
Yes, ma'am.
easy to compare rather than comparing with the Canadian
Yes.
population or for the
Yes,
Japanese
ma'am.
population.
Yes,
You
ma'am,
know,
I
so
agree
it will
with
be
that.
better
Yes, ma'am.
if we compare it with our own ethnic group.
Yes,
You
ma'am.
know, so that is one thing.
Yes, ma'am.
So now, since you've also standardized the methodology and you've written, I think, a book about, have you written something about this?
Ma'am, my book that I was actually talking about is actually on the competency part. It is not
Okay,
related to the
okay,
article
okay.
fitness part.
So it would be a good idea if you put your methodology and whatever it is in a book form, you know, you kind of standardize, because as I'm saying, you know what happens, people in different parts are making data,
Ji, ma'am.
their own procedure, their own ups and downs.
Yes, ma'am.
If it is available to the general people, so
Yes,
a
ma'am.
lot of time will be, you know, used beneficially.
Yes, ma'am. That is
Rather
what
than everybody, you know, copying and doing the same thing again and again, and
ma'am.
everybody may not be able to reach out to you or to the lab at AIMS.
Ma'am.
So I think that you guys are the best people who can, you know, at least make it available at the national level.
Thank you so much,
You
ma'am.
know?
I'll pass on this suggestion to
Yes,
sir and my team.
definitely.
Yes,
And third thing I want to ask is
Yes.
that what you did it in normal populations,
Yes, ma'am.
and what were the applied aspect, and what diseases you kind of saw the variations?
Ma'am, again, in my particular study, that was intended at comparison of Valsalva and LBNP in the healthy population.
Okay.
Another study what I have been a part of is where we have done the comparison in central serous retinopathy and healthy subjects, ma'am. That was a tie-up with the ophthalmology department.
Yes.
Now, ma'am, in CSR, they say that sympathetic dysfunction is what is leading to the fluid accumulation in retina, then between the pigmentary and the basal layer. But we did not find any difference between the two groups, ma'am. Contrary to what? So that also, ma'am, we are in the part of publishing. So these two populations are what I have worked upon. Again, my colleagues, ma'am, they have experience with chronic kidney disease and all. That will come in the later part of the talk, ma'am. Yeah.
That's very nice. And are you following this up at Jodhpur? Are you continuing with this?
Ma'am, we have, as of now, we don't have beat-to-beat blood pressure right there. We are in the process of acquiring it. So as soon as we get it, ma'am, we would go ahead with the, again, with support of ma'am sitting here, we would like to go ahead with the acquisition of, again, normogram for our population and then explore to different disease parameters, ma'am.
Okay. So, and last question.
Yes, ma'am.
One thing is which is written in the, say, papers or the books.
Ma'am.
Did you find any personal variation, like you said, beat to beat? Did you find something different from what was written?
Ma'am, one interesting thing again, as what I noticed is that again, when we perform BRS estimation during different methods, the values are different. For example, in sequence method for a healthy subject, it will come out to be in the range of something like 18 to 20. While for Valsalva, it will be something in the range of 4 to 6. This is because, ma'am, these pathways are acting by different neural pathways, different organ structures are involved, and the net effect is different. Now this again, ma'am, has been explored in literature, and they said no method is superior to other. We should stick to one method, have a standardized recording frame methodology, and we should use a single technique for analysis. So that way, ma'am, we have consistency in our observations, ma'am.
Thank you so much.
Thank you so much.
Anybody else would like to ask anything?
Ma'am, please, ma'am. Yes. Ma'am. Thank you, ma'am. Thank you.
A very nice presentation. I congratulate you for your excellent work that you've done. So I have two questions. The first is, yes, so the first question is, there is this 6-degree head up tilt that we, head down tilt that is. So
Ma'am.
why is it at 6 degrees? Have you,
Ma'am, again, ma'am, 6-degree head down tilt, ma'am, that is used actually that is used as a simulation of the low gravity environment. Ma'am, what is happening is that in the microgravity or low gravity environment, that the gravitational induced pulling in the capacitance vessel that is actually nullified, and all the blood moves from the peripheral to the central compartment. And it has been seen, ma'am, if we give prolonged 6-degree head down rest, so it will mimic the microgravity environment. So, ma'am, it has been shown in literature, again, these studies that are done are primarily on astronauts or people training for that purpose, in which long duration 6-degree head down bed rest has been with a simulator of microgravity, ma'am. So that has been standardized.
particular reason for 6 degrees only?
Ma'am, I don't know why particular, why not 7 or 5, but that is what I found in literature, ma'am.
And
Yes,
one more thing, that you have done this lower body negative
Yes,
pressure.
ma'am.
What equipment was used?
Ma'am, for lower body negative pressure, ma'am, we use a vacuum sport equipment that is again a German equipment that is creating a seal using a parachute cloth at the level of the iliac crest and applying suction. But
What is
again,
the
I would,
cost of it?
ma'am, again, what I would go out to say is, ma'am, this equipment can be made easily fabricated. All we need is a drum, a pump, and a circuit to control the level of pressure and something to create a seal. So, ma'am, if we have again tried to design something of an indigenous equipment, I don't know, it will be something like between 50,000 to 1 lakh will be able to design. The German equipment which is there, that is primarily used by sports physiology people, ma'am.
Okay.
The South African cricket team, they use it on a regular basis for their fast bowlers. So that device is something in the range of 50 lakhs, if I will, ma'am.
So as you summarize that no method you found to be no method was found to be superior
Yes, ma'am.
over other.
Yes, ma'am.
So what would you recommend, like financially, if you look at it, that is always a consideration.
Yes, ma'am.
So which method would you recommend for our PG students and for all of us?
Ma'am, again, the constraint in ma'am doing BRS at different center is the availability of beat to beat BP data. That actually becomes a costly equipment and is difficult to acquire for the department. Ma'am, what I would recommend, what I spoke to my colleagues at in my institute was that anesthesia people, they often place a central an arterial line in many of the procedures. So that signal is available for us to explore, and using that, ma'am, we can actually have that continuous BP data for a segment of rest of 5 minutes or maybe longer, and ECG is available, ma'am. So the best method would be, if you don't want to go into any provocative measure, or what would be a sequence method, that is resting BP data of 5 minutes duration, that would be sufficient. Or also, ma'am, Valsalva and head down tilt, head up tilt, sorry, ma'am. They can also be easily performed in the lab and can be
That
used.
is a 60 degrees head up.
60 degree
Okay.
head up tilt.
Thank you so
Thank you
much.
so much, ma'am. Thank you.
Anybody else? We can have the next speaker. Next speaker, less questions.
Yeah.
Good morning. Now I have the privilege of introducing Dr. Manpreet Kaur. She is an associate professor of physiology at Vardhaman Medical College and Safdarjung Hospital, New Delhi. The areas of research are autonomic neuroscience and vascular physiology. And she has an expertise in assessment of autonomic and vascular functions. And she has established the clinical autonomic function reporting at VMMC. And naturally, she has several research awards and research papers to her name. And her recent work is on correlation of structural atrophy of central autonomic network with the functional attributes of autonomic system in spinocerebellar ataxia patients. And today she shall be talking upon vascular health assessment using arterial stiffness, the principle and recent advances.
Thank you so much
Welcome,
for your
Dr.
wonderful
Manpreet.
introduction, ma'am. It's a pleasure to be here at ESI and get this opportunity to share my work. So, to begin with, so let's get up to the next stop. Like ma'am said that, very pertinent question she asked. If I have to choose one technique, should I do with one? Should I just choose baroreflex sensitivity and talk about vascular function? So it's not feasible. So I'll try and discuss in my talk, why a holistic approach is required, because we are looking into a comprehensive evaluation of the cardiovascular health. So I'll just try and, cater on that question as well. So health. So we've been, testing cardiac, stress test and echo, all of this been going around throughout. So why suddenly so much of focus on vascular health? So I'll be talking about why we need to do that. How do we go about assessing vascular health? And then the key area of my talk would be arterial stiffness. Why is the hero of vascular health being, being speculated to be this arterial stiffness parameter? How do we measure it? And I'll be sharing my research journey. Very pertinent question ma'am asked, how many subjects have you actually recorded and how does it change in disease? So I'll be sharing my research journey to just give you a live example of how this vascular health using arterial stiffness could be used for clinical application. And finally, what is our role? So why are we having a talk in a physiology conference about vascular health assessment? So I'll be discussing about that. So we know that the cardiovascular system, as the name suggests, has two components, the cardiac component, the vascular component. The only test that we are these days using for vascular assessment is a invasive test called angiography. If you look at the cardiovascular disease classification, the four predominant cardiovascular diseases are coronary artery disease, aortic atherosclerosis, cerebrovascular disease, and peripheral arterial disease. So you see, on all four of them, there is an arterial component which is being affected. But are we assessing it? No. When we do a stress echo, we are looking for the cardiac viability. When we do a echo, we are looking for the left ventricular function. When we do a ECG, we are only looking at the activity of heart. But what about the vascular component? So we need to assess the vascular component because now it is emerging in a non-invasive manner, which can be done by physiologists like us, give us an early detection of disease disorders. Before the cardiac pathology begins, we are able to detect disorders. So the good thing about vascular function testing is they are easily done, they are early marker, they're giving you a comprehensive picture because you're trying to find out what is the level of defect and how is it leading to a pathology later on. So that is why it will help you in better risk management and future treatment of the patient. See, now we are at a level of drugs being emerging. So we have to find out the earliest level of pathology so that we can stop the process there before we end up with complications. So how to measure vascular health? Now in literature, we see that predominantly you have three types of assessment which are used for vascular assessment. Either it is a photoplethysmographic based changes in amplitude and transit time, or a flow mediated dilation, which is a protocol used for endothelial function. But the most validated measure which is emerging is to be the arterial stiffness, so which we would be talking in detail. So what is arterial stiffness? Now as the name suggests, it's just the opposite of compliance. So in simple terms, it is just the loss of arterial elasticity. So how do we study this? And why we study this? Now it has been established that if the arterial stiffness, specifically the central arterial stiffness, is raised, these patients have a 10-year predictive value of having higher myocardial infarctions, higher cardiac death, higher all-cause mortality. So it's been proven to be a predictor of all-cause as well as cardiovascular mortality and morbidity. Now it has been seen that we know that stiffness changes with age. We teach students that when you do a radial pulse examination, in aged patients, you will be having a cord-like structure. That is nothing but the stiffening which is changing. So it is emerging as a parameter for aging. Diabetes, dyslipidemia, all the disorders we can think of, everything, the stiffness is being affected. So that is why this is being, the new pro for a vascular health assessment. So what happens if arteries become stiff? Now arterial stiffness principally starts at the level of elastic arteries, the central arteries like aorta. And once this happens, we know that the Windkessel effect that we teach our students is responsible for two things. First thing is it does not allow the systolic pressure to rise beyond the level so that the cardiac workload is not increased. The second effect is that during diastole it ensures sufficient perfusion of the coronaries. Right? So if the arteries become stiff, specifically the central arteries, what would happen is we will end up with higher systolic pressure. That means the heart has to work against higher pressure. So it will end up with hypertrophy and maybe later on ischemia. At the same time, the lower diastolic pressure again would impair the diastolic perfusion of coronaries and lead to myocardial ischemia. So this change, this increase in systolic pressure and fall in diastolic pressure will widen the pulse pressure. And this widening pulse pressure means higher oscillatory stress to your vital organs like kidney, brain, and that is why it also can lead to end up in conditions like stroke. At the same time, the stiffness of aorta results in endothelial injury because the shear stress is increased. And that will lead to finally increased risk of further atherosclerosis. So in all ways, the stiffness is being, the central parameter leading to multiple complications. So if you detect it early, you will be able to stop someone from ending up in these complications. That is why we are talking about stiffness assessment. So how do we assess it? So in literature, you would see, like we saw, pulse pressure was widening when somebody was having a stiff aorta. So it is the simplest technique which can be done by any clinician at bedside. So if you find a widened pulse pressure, you might think that this person is having a increase in arterial stiffness. But the problem with pulse pressure is that normally we are measuring the peripheral pulse pressure. But once when the pulse travels from the central arteries to the peripheral arteries, there is a process of augmentation. Okay, so that is why we need to look at the central pulse pressure. Now most techniques that we do, only a invasive angiography would be allowing you to get central pressures. Otherwise you cannot find out the central pressures. That is why pulse pressure is not being used as an index of arterial stiffness. But now we have newer techniques I'll be talking about where you can indirectly, from a peripheral artery waveform, you can predict the central pressures, which is being done by some companies. I'll talk about that. But central pulse pressure is what we should be looking at, and that is why it is not a very keenly used index. The second index is the compliance. So compliance, like I said, is the opposite of stiffness. So it is measured by finding out the change in a vessel diameter with the given pressure pulse. So you keep an ultrasound probe at an artery and you change the pressure by giving some stimulus, and then you see how the arterial diameter changes. Now the problem with compliance measurement is that it can only be done in larger arteries which are accessible, and you need to simultaneously record the blood pressure so that you know ki kaise pressure change was happening and how it was leading to diameter change. And it's a highly operator dependent technique. That means if your operator is not able to detect the change in diameter correctly through the ultrasonic technique, your measurements will be erroneous. So that is why the two parameters which are being now clinically used are the pulse wave velocity and augmentation index, which I will be talking about. So now, as the name suggests, pulse wave velocity means the speed of travel of a pulse wave. So it has been seen that the pulse wave velocity is inversely related to square root of compliance. So that means stiffer the vessel, higher will be the velocity of travel. And it can be recorded using a pressure, flow or volume signal, but the pressure signal is most accurate because it is a wave which, it can be easily measured through probes. So that is why pressure signal is being preferred. So how do we estimate pulse wave velocity? So as we know, for velocity estimation, you require, a arterial segment. If you have two transducers available, two applanation tonometer transducers which can measure the pressure wave, you can simultaneously keep them at the two sides and you can record the pressure signal at the two sides. And by knowing the distance between the two sides, and you can compute the time difference from the proximal to the distal side. For example, in my thesis I use carotid femoral pulse wave velocity. So a probe could be kept at the carotid artery and at the femoral artery, and you would get two pressure wave. You find out the travel distance, time taken from the carotid to the femoral, and distance you can calculate through certain formulas which are validated, because ideally you do not know how the arterial segment is inside your body, so there are formulas for that. So with that you can find out the velocity. Distance divided by time gives you the velocity. But most now the techniques are changing, but when I started my thesis there was only a single transducer which was provided to us. So what we did was we gated it with the R wave. That means we recorded the pressure wave signal and we recorded at one site initially, and consequently we recorded at the second site. So we got two distance, T1 and T2. By subtracting T1 and T2, we could compute the time taken for it to travel from one side to the next site. And by knowing the distance, we could calculate the velocity. So this is a typical record which is of my thesis, where we saw that, this is an instrument called SpigmoCore, which gives you, it's an FDA approved equipment for clinical use. So here you could see two sites, side B was carotid, side A was femoral. The time are being computed from the 10 to 14 waves so that we are very accurate. And using the delta t and the distance that we add in the software, we can compute the pulse wave velocity. The next index of interest is the augmentation index. Now, with pulse wave velocity, it has emerged as a gold standard, while augmentation index is affected by central arterial stiffness, but also some other parameters like sympathetic tone. So we'll be talking about it as well. So now it is based upon the concept there are two waves. When the heart contracts, you have an incident pressure wave being generated. When this pressure wave travels through the arteries at branching points, wherever the resistance changes, there is a reflected wave component which is coming back. So when you keep your probe at a central artery, you record what we see over here as depicted as a black pressure wave, which is a composite wave generated with the components, both the forward and the reflected component. So the concept of augmentation index is when the arteries are stiff, the reflected wave, which normally comes back in late systole, comes back earlier. So this earlier reflected wave component increases the systolic pressure wave, like we can see over here, this delta pressure change. It has changed from P1 to P2 because of the reflected component coming early. At the same time, if you look at the diastolic waveform, it has become bleaker, right? So this, what we quantify over here is the change in the delta P because of the reflected wave coming earlier. So this index is calculated, which is known as augmentation index, which is nothing but the augmented pressure, which was delta P divided by the pulse pressure. And this index is also used for, say, as an index of central arterial stiffness. Now the problem is that the reflected wave can come early because of change in tone of the blood vessel as well. So that means whenever there is an increase in sympathetic activity, the reflected wave component normally also comes faster. So what happens is it is not truly affected only by the arterial stiffness component, but it can also be affected by peripheral muscular arteries being affected by the tone changes. So that is why it is an index of systemic arterial compliance. It is known as a index of systemic arterial compliance, while pulse wave velocity, specifically of the central arteries, is truly an index which is only affected by changes in arterial stiffness. So this is a typical graph that of a report that we used to generate using SpigmoCall, where the operator index is generated. So this technique will only produce a report when the recording is appropriate. It is called inherent checkpoints. So this technique is not operator dependent like the compliance measurement which we were doing through a ultrasonography. So now I'll start with my journey, where we started with a question that interestingly the chronic kidney disease patients die not because of the kidney disease but because of cardiovascular disorders. So the question was, why such a high cardiovascular mortality in this group? So what we started to assess was the entire cardiovascular system in this group of patients. So we know that the baroreceptors are placed in the adventitia of large arteries. So this was the sensor compartment, and the effector organs are the blood vessels as well as the heart. And then we have the central component, which is the cardiovascular brainstem centers, which are regulating the entire cardiovascular functioning. So we used the arterial stiffness parameter to assess the sensor compartment. Then we used the vascular reactivity as a parameter to find out about the efferent along with heart rate variability. And then we also used baroreflex sensitivity to talk about the entire loop functioning. So this was done for chronic kidney disease patients. So my research journey at AIIMS was from 2008 to 2018. So we had 2 cross-sectional studies, and we published it as well. So the one here, the red labeled ones are the number of publications we generated with these studies, and we also had longitudinal studies, and my thesis was also a longitudinal study in patients who were undergoing renal transplantation, wherein we had 3 publications, and all this was followed up by another research idea generated in my thesis was followed up for a DM student, and there also we published with 2 publications. So this field we had overall 7 publications coming up from a lab. So the first study was how chronic kidney disease patients had were differed from healthy controls in terms of their vascular function, and to assess any relationship between the vascular and the autonomic limb. So what we found was, this was published in Indian Journal of Nephrology, and what we found that as expected, they had stiffer blood vessels. That means chronic kidney disease was increasing the arterial stiffness, so the velocity was higher. They had a reduced baroreflex sensitivity. That means the baroreflex functioning was also affected, and the heart rate variability was found to be reduced in the patient groups. So they were having a poor hemodynamic profile. But as we were thinking, yeah, maybe the baroreflex function has a correlation with arterial stiffness, then we know the level of defect is the sensor compartment. Sensor compartment is being affected, that is why BRS is low. But we did not find any such correlation in this study. Later on, we followed it up with another study where the group was comprising of those on peritoneal dialysis. So how does peritoneal dialysis affect the vascular function? So what we found in this study was, this was published in Clinical Experiment Nephrology, that these patients, the BRS was lower, like we saw in the previous study, and the pulse wave velocity was higher, and the HRV was lower, which is in sync with the previous study that we had. But if we compare those on peritoneal dialysis with those who were not on peritoneal dialysis, unlike with what we would expect peritoneal dialysis are being treated, so they might be having better hemodynamic profile. It was the other way around. The BRS was lower in this group, the pulse wave velocity was higher in this group. So they were having stiffer vessels, less baroreflex sensitivity. That means peritoneal dialysis is not a very good parameter if you're looking at vascular health in these group of patients. So, but what correlation we could not find in our first study, we found in this study where the pulse wave velocity was negatively associated with baroreflex sensitivity, and as you can look at the Spearman R, clinically relevance 0.7, anything more than 0.7 is said to be clinically relevant correlation. So it was for the first time that we reported that there is a relationship between baroreflex sensitivity and pulse wave velocity, and probably in kidney disease patients, the sensor compartment is being affected, which is resulting into the lower baroreflex sensitivity in these group of patients. The third study was my thesis studies, where we had basically planned a follow-up study to find out the time kinetics, the temporal relationship between these parameters, how they are changing over time. See, when you transplant a patient, does stiffness change or does the neural component change with baroreflex sensitivity? So this is what we were looking for. And we had published our first study of 3 months in again clinical experiment nephrology, where we found a significant reduction in augmentation index. That means stiffness changed as early as 3 months after renal transplant. So transplant is a very good treatment modality for these patients to decrease their cardiovascular mortality. And we also found that with clinical parameters, which were obviously improving after renal transplant, there was a strong correlation with the changes in the stiffness we found. That means if the mineral metabolism, which is shown by calcium phosphate, improves, stiffness became less. And if the creatinine or the urumic toxins are getting less, the stiffness became less. So then we further completed our follow-up study of 6 months and published in Nephrol Dial Transplantation. This was an editor's choice article with blog commentary. And as we know, this is a very high impact factor in nephrology journal, and where we reported that by 3 months, with the changes in the GFR or the stiffness parameter along with blood pressure variability going low, BPV became less and central pulse pressure also became less. So this was all happening as early as 3 months. But the baroreflex sensitivity only improved at 6 months post-transplant. So this tells us the stiffness changes precede the changes in the baroreflex sensitivity. So probably it is the stiffness which is resulting to an impaired baroreflex sensitivity in this study group. So this was, we also found a correlation between stiffness parameter and BRS in our study group. And then we proposed a model based upon these temporal changes, that the augmentation index and central pulse pressure improved, which lead to improvement in BRS, which lead to dampening of the blood pressure variability. See, baroreflex are short-term regulators of blood pressure. So what they normally do is they increase the heart rate variability and they try to keep the blood pressure variability as low as possible. So if your BRS is functioning nicely, it is normally seen that BPV is low and HRV is high. So we proposed a model in our paper stating how it is changing by renal transplantation in these group of patients. Later on, we had got an invitation to write a review article, and we also wrote a review article in this field where we proposed what could be the level of defects in chronic kidney disease patients. So level 1, 2, 3 and 4, could be the level of defect. But according to our study, this defect was primarily at level 1, which is the sensor compartment. So later on, this study was further followed up in a DM student's thesis, where he again had a follow-up design on a larger sample size. In my studies, it was just a 30 patient group. Here it is a 75 patient group followed up for 3 time points. So the data recording for them was 75 into 3. So in my study itself, we had recorded more than 500 for barrel-flex sensitivity, stiffness, as well as the vascular reactivity. So, so the amount of data generated during my span must have been more than 2,000 patients during my tenure itself in these parameters. So then what we found out was, we've also published this recently, and we found out something which was very contrasting to my study. Here, the HRV improved as early as 3 months, and this HRV component was correlated with the changes in BRS. So that means the neural component was suddenly showing improvement and the vascular was not showing any change. The question was, why is it so different from my study? Same place, same cohort of patients being getting up. So when we looked at the baseline pulse wave velocity, the patient in my study had higher baseline pulse wave velocity as compared to this study. So this means that patients may differ in their time course depending upon whether they already have a high stiffness or whether they have a predominant neural function. So that is why we also decided to have another follow-up study to find out what decides whether there will be a vascular improvement or a neural improvement in the study group, and maybe use artificial intelligence to predict for this for the clinicians. But that study is being it has to be formalized now. So with this, I end up with my research story. So now the question is, what is the future of vascular health assessment? So we have development of indigenous technologies, like IIT Madras and AIIMS Delhi is developing a indigenous vascular health assessment parameter, which will give us velocity and central pulse pressure also. It will be a low-cost equipment, but it is at the level of research right now. These techniques are feasible and can be performed, and with my example, I tried to share because we are in a good position to help the clinicians in future, specifically with the emergence of arterial intelligence techniques and it has got huge translational value. So let's hand in with the clinical departments, and let's take the physiology to the clinics. Thank you so much. Sorry for being too long.
Thank you, Dr. Manpreet. Yeah. Oh. Yeah. Just one question. You've talked about kidney disease. You've talked about your results. How is it different or similar to other people who have done?
In chronic kidney disease patients?
Yes.
Ma'am, actually, interestingly, we were the only study research group in worldwide who had worked with all these parameters together.
Okay.
So most people were just doing stiffness in kidney disease patients, that it was not telling them anything. Okay. So when we started, we were the only group who tried to assess the barrel flex sensitivity with stiffness and reactivity together. Okay. So that is why so many publications came from our lab, and I would thank Dr. Deepak and Dr. Jaryal for their keen ideas.
And now also you are the only one, or people have taken it up?
Ma'am, people have taken up, but there are still only 3 or 4 labs in the world, and there are just 2 publications which have come up in this study field right now.
Yeah, which
are very similar to us, but following the trail, they still don't answer the question completely, because sample size for a longitudinal study, follow-up design is a very difficult thing to conduct. But they have started using artificial intelligence. So that was the idea which I started with, but we haven't been able to pursue it further.
Okay, now
Thank you. Yeah. It is being used, ma'am. Yes. Ma'am, the problem with pulse transit time is the foot wave detection, which is not very accurate. When you go for a volume signal, see, it is basically done with PPG signal. Volume signal is affected multiple factors, like the color of the skin, and changes in the skin. Sometimes a person might be having skin thickness, pigmentation problems. So signal detection is a problem and it's highly erroneous. But it is an index which is indirectly used at many places. Even our lab started with pulse transit time. So the initial 3-4 publications of vascular function were based upon pulse transit time. And we can use it. But when we go for something which is to be used for the clinics, normally we want something which is, foolproof and, more further on, you can rely on its result. But pulse transit time is being used. Tonometry. Ma'am, basically it basically detects the pressure signal. So tonometer is a piezoelectric crystal. So any changes in the mechanical pressure is changed into an electrical signal, and that is being generated in the form of a pressure wave.
Then we go to the next person. Dr. Kiran. Welcome, Dr. Kiran. I have the privilege of introducing you. Dr. Kiran Prakash is an assistant professor of physiology at GMC Hospital, Chandigarh. She is trained in assessment of various autonomic and vascular functions naturally and has contributed significantly to understanding of autonomic and vascular physiology, numerous studies and research projects, and several awards, including the Young Scientist National Award in Physiology in 2020. So congratulations for that. Her most recent work is on association of heart rate variability, blood pressure variability, and baroreflex sensitivity with gastric motility during rest and during cold pressure stress. Today she will be talking about transcranial Doppler ultrasonography to assess cerebrovascular endothelial function and autoregulation.
Okay. Thank you, ma'am. Thank you very much for the kind introduction. So, as we all have learned about the systemic arterial stiffness and baroreflex sensitivity, so I am just highlighting few things about the cerebral vascular functions. So, before actually going to the cerebrovascular function, I will just want to introduce about the tool which is being involved. So, it is basically the time assessment. And this is the very distinct feature of this instrument, because the other instrument which we usually use, such as MRI or other things, we have to wait for some reports. And that real-time assessment, that's why because of its this property, this is many a times is also called the stethoscope of the brain. So we get immediate result whatever we are measuring about. And briefly going to the setup of this. So there is an ultrasound probe, briefly a specialized ultrasound probe, and from that ultrasound probe, the blood flow velocities are being measured, and after being analyzed, and then it is being displayed. Just we will go a brief, a bit of the detail of this instrument. So before going to further, a brief basically physiology behind that. What is the basic principle which is being employed by this instrument? So we all know about the Doppler effect. So Doppler effect is basically when the source or the recipient is moving, the perceived frequency is being changed. And the same principle is applied here also. Here basically what happens that the ultrasound probe is being used to insonate the specific artery of the cerebral vascular. Suppose any artery we are insonating. So the blood RBCs are moving there, and these moving RBCs basically reflect the incident ultrasonic waves. Now, the blood flowing into the vessel, all the RBCs are not basically moving with the same speed. So the reflected waves, reflected ultrasound waves, which are being perceived by the ultrasound sensor machine, they receive the complex waveform. And that's why this complex waveform has to be further analyzed. So fast Fourier transformation is applied here. And the fast Fourier transformation, it basically separates the Doppler signal, which has been received by the ultrasound probe, into its component Doppler shift frequencies. And these Doppler shift frequencies are then converted by the formula into the Doppler velocities. Now, these Doppler velocities are then displayed. So the velocities are displayed by the bin or by the colored dots, and the brightness of the bin or the color of the dots are basically determined by primarily the volume of the RBCs which are reflecting those specific waves. So here just it is the diagrammatic representation, one by the different brightness of the bin and the different color dots. Two types of TCTs basically represented, the blood flow velocities can be represented here. So here I am showing just one of the representative, just a record of the cerebral blood flow velocity. The first image is showing, the first image is basically showing the record in the 4 panels. So the first one, the uppermost panel is showing the waveform of the what we have learned about, that the fast Fourier transformation has been done and the waveform is presented here. The second panel is showing the spectral window. Here in the spectral window, in the y-axis, I think it is not very clear, in the y-axis the depth is being shown. So since the 2D ultrasound is not being used here, the grayscale ultrasound is not being used here, so identification of the artery insonated depends upon few of the helping parameters. One of the helping parameters is the depth at which the artery has been insonating and we are getting the signal. Again, the direction of the flow, that whether the blood is moving towards the probe or away the probe. And another thing is the lower 2 panels are basically the trend window and M, they are showing the monitoring M mode of the waveforms. We'll come to it later. But the right side diagram, which right side picture is showing the TCD or the blood flow velocity is usually used commonly in the clinical departments. So there basically only 2 windows are being shown, the waveform and the spectral window, and that is sufficient for the clinical department. But when we are talking about the physiologist, we have to go much deeper, and how come these 4 windows are helping, we'll get to know in the later slides. So here we just already talked about that, how to identify, since it is not the B mode of the ultrasound and we have to identify the vessel specifically. So other criteria are being used by which we identify different blood vessels. So which acoustic window we are using here. So here, when we have talked about the ultrasound, the probe, ultrasound probe. So since the blood flow, cerebral blood vessel, that complex is within the skull, so we use the different thin part of the skull, and from there the ultrasound waves are being impeded on these specific vessels to identify different arteries, different major arteries of the circle of Willis here, basically. So 3 windows are being used, and those are basically orbital, transtemporal, and suboccipital. One submandibular window is being used, but that is for the extracranial part of some other major arteries. But as far as intracranial arteries are concerned, orbital, transtemporal, and suboccipital windows are being used. Here in the right side diagram, the green box is showing that is the orbital window. From that orbital window, we usually insonate the ophthalmic and internal carotid artery siphons, and most commonly used is the transtemporal window. And from that, we insonate or identify basically the middle cerebral artery, anterior and posterior cerebral artery, and from the suboccipital window, we usually identify the vertebral and basilar artery. So by using different criteria, we identify the assessing the depth, at which depth we are getting the signal from, the flow of direction, the mean velocity which we are getting. From that, we basically identify different cerebral blood vessels. So TCD is being usually used, sorry for. So this transcranial Doppler ultrasound machine is very commonly used by clinical neurology department and other clinical department, and its role is established in various indications such as stroke or in steno-occlusive diseases, in vasospasm, identifying cerebral microemboli. Long list is there. So where's the role of the physiologist comes? So usually we have the role in the functional assessment, where the impending damage we have to predict and we have to prevent the disease to get happen, or to assess the in physiological conditions, what is the cerebrovascular function. So basically, assessment of cerebral autoregulation and cerebrovascular reactivity. From that, what different basically what different functions we can get to know about, we have to focus on that. So what is the cerebrovascular reactivity? Coming to the main point. So it is basically changes in the cerebral hemodynamics in response to adequate stimulus. So these different, it has been found that cerebrovascular reactivity goes very well hand to hand and let us know about the cerebral endothelial function as well as the cerebral autoregulation. So different cerebral hemodynamics which we can get from the TCD. So that is the cerebral blood flow velocity, but many other derived parameters can also be we get from this cerebrovascular blood flow velocity, and that is pulsatility index, resistivity index. These two indices let us know about the vascular resistance. Lin-Card ratio is there, cerebrovascular conductance is there. So a bit detail, I will discuss these things in further slides. And different stimulus which can be induced to alter the cerebral hemodynamics and to induce the vasomotor reactivity, cerebral vascular reactivity. Commonly employed stimulus is the carbon dioxide. So carbon dioxide is a good vasodilator, and we can employ various techniques such as rebreathing technique or asking the individual to inhale the carbon dioxide, having the fixed carbon dioxide concentration there, or ask the subject to breath hold, and just looking at that how come the cerebral hemodynamics are changing after this stimulus. Many papers have initially used that thigh cuff maneuver. So suddenly by thigh cuff maneuver, suddenly decreasing the systemic blood pressure, and how come this is affecting the cerebral vasculature and their response. So by that also cerebral vasomotor reactivity has been assessed. Other methods are also has been used. So here I am showing just the typical classical example of the how come cerebral blood flow velocity has responded to the breath holding technique. So we have asked the individual to hold his breath for 30 seconds, and here we can very well see that velocity at the baseline, which was approximately 58 centimeter per second, at the end of the 30-second breath hold, it has become 74 centimeter per second. So the breath holding index can be calculated, and it is simply the percent change in the blood flow velocity as compared to the baseline values. So here another example of 7% of CO2 inhalation is there, and here also by changing the percentage change in the blood flow velocity as compared to the baseline, the index has been calculated. But here now few precautions we have to take care, and that is that while here what we are doing, while calculating the index, we are normalizing the change in the blood flow velocity to its baseline value. Now this normalization has to be and taken with a bit of the care, because normalization assumes that changes in the velocity in response to hypercapnia are directly proportional to their respective baseline value. But what if the baseline value already is altered in some disease condition? So this assumption does not justify the disease condition, as because in the impaired endothelial function, in any disease condition, autoregulation endothelial function at the baseline is already altered. So here the normalization will not assess the actual vasomotor reactivity. And we are basically, whatever the change is there, we are reducing that by normalizing it with the baseline velocity. And another thing is that when we are using the carbon dioxide as a stimulus, what happens? CO2 itself increases the systemic blood pressure. Now systemic blood pressure is the driving force for the cerebral blood flow velocity. So increase in blood pressure itself will cause the non-endothelium dependent increase in the cerebral blood flow velocity. Especially in disease condition where autoregulation is already impaired, this increased systemic blood flow velocity will be reflected in the form of increase in cerebral blood flow velocity. So again here we are pseudo normalizing the R data. So cerebrovascular conductance index calculation will take care of this. Here what we are doing, we are dividing the blood flow velocity with that of the systemic arterial blood pressure, and this conductance index has been shown to be a physiologically more plausible index as compared to the previously discussed just absolute changes or percentage changes in the blood flow velocity. So this has been shown in one of our study, and here we are showing that in this study we have calculated the cerebrovascular reactivity, systemic endothelial function, and insulin resistance in the patients of diabetes mellitus. And when we didn't corrected these blood flow velocity for the systemic blood pressure, then we didn't find any correlation among these parameters. But when we corrected this blood flow velocity for the systemic blood pressure, we actually find a significant correlation between systemic and cerebral endothelial function. later on when we took the absolute value rather than the percentage value. So we didn't normalize the reactivity changes to the baseline value, and after correcting that, we found the significant correlation with the cerebral vascular, within the cerebral endothelial function with that of the systemic as well as the insulin resistance. So that's why we say that we conclude that, hypothesize that, yes, cerebrovascular reactivity assessed as a absolute changes in the cerebrovascular conductance index is physiologically more plausible index. Now, the same data is shown here, that how come correction with the for the systemic blood pressure has increases the correlation between different parameters. So now coming on to the cerebral autoregulation. We all know cerebral autoregulation is basically the intrinsic ability of the brain to maintain an adequate cerebral perfusion in the presence of the BP systemic blood pressure changes. And we know that despite change in the systemic blood pressure, cerebral autoregulation tries to maintain the cerebral blood flow at a relatively constant level. So cerebral autoregulation has also been calculated, assessed by many methods, and it is, again, it is not clinically used in regular process, it is still in the research process, but many group of researchers have done this. So cerebral autoregulation can be calculated during static and dynamic cerebral dynamic phases of any vasomotor reactivity test. So what is basically static phases? So static phases are when with time the parameters are not very much changing. So during the baseline, suppose we are assessing the cerebral autoregulation, or during the plateau phase of any vasomotor, suppose we have asked the individual to inhale the 7% of the carbon dioxide. Now after 1 minute to 1 to 2 minutes, the plateau phase is reached. So during the plateau phases, when we are calculating the cerebral autoregulation, these are the static cerebral autoregulation. During the slope phase of the stimulus response test, during the slope phase, that with time there is increase in cerebral blood flow velocity as well as the blood flow velocity. And during that, when we calculate the cerebral autoregulation, this is regarded as the dynamic cerebral autoregulation. So here basically for the transfer function analysis is employed. So how come the systemic blood pressure and cerebral blood flow responses are changing and going in hand to hand? This is being quantified by transfer function analysis in the form of coherence or in the form of phase shift. So many newer parameters has been introduced. Now, as we know, whatever the systemic blood pressure is changing, if the BP and blood flow velocity, cerebral blood flow velocities are going in hand, more coherence is being seen. That means autoregulation is impaired at some level. If cerebral blood flow is able to not to get much change in response to systemic blood pressure, that means coherence is less. That means autoregulation is much better. So few papers are there where the baseline, all the time we didn't have to introduce some stimulus. One paper has introduced that, okay, whatever spontaneous blood flow velocity is there, spontaneously changing blood pressure is there, the coherence between in that spontaneous changes, that the cerebral in the blood flow velocity is being compared with the extracranial blood flow velocity. So if suppose it is more than 3, that means the intracerebral blood flow velocity is much more increased as compared to the systemic, and this indicates that some vasospasm is there. So it is commonly employed, Linkard ratio is commonly used in the emergency departments. And so just to summarize, cerebrovascular reactivity very well assesses and give a reliable value about the cerebral endothelial function as well as the cerebral autoregulation. And if we take the good care of confounding factors, it acts as a better predictor of impending cerebrovascular damage. And before completing, so we have already covered the baroreceptors thing by Dr. Shival, arterial stiffness from Dr. Manpreet. And I just want to thank our mentor, Dr. Ashok Jairal is here, and Professor Deepak, and we all three are students of our guide and mentor. So thank you, sir, and thank you.
Thank you, Dr. Kiran.
Thank you,
I'm
ma'am.
so delighted to see that from the main roots, the branches are coming out in different institutions, and
And
they've talked about different parameters, from beginning from arterial stiffness and the baroreflex sensitivity, and now you're talking about transcranial lateral sound. So I'm very glad, and
Thank
I
you.
am happy that your guides were able to modify this and see different aspects, and now you're in different institute. I
Yes.
would just like to ask you one thing about your transcranial ultrasound. So
Yes.
you've done it in, you've formulated your own lab, I think. You must
Yes,
have done that.
initially I was
Huh.
at AIMS New Delhi, and my thesis work was on transcranial Doppler. Whatever presented, the work I have presented,
Yeah.
and 90% is from that lab
Yeah.
only. And
Okay, so you
presently,
continue it to 150% now. Yes.
yes, sure,
Yeah,
ma'am.
take it
Yeah.
further and formulate your own data. And
Yes,
now
ma'am.
that you are from the same roots, so it will be easier for you to come together. Our
Sure, ma'am.
aim should be that
Yes, ma'am.
at one point of time,
Yes, ma'am.
we say that, okay, this is a healthy person, this is a potential patient of cardiovascular
Yeah, sure,
dysfunction,
ma'am.
and this is a patient of cardiovascular dysfunction. And this is a paper with these tests and these normal values, and here take it and do it and say what is the damage.
Yeah, sure, ma'am.
There.
Sure, sure.
So you are going to reach there.
Yes, ma'am.
For you to reach there,
In the process,
yes.
their
So
guidance,
you
yes.
do your own normative datas, but do it together. When we don't want 10 or 20 years for this paper to come out. We want it in next 5 years.
Yeah, sure,
You
ma'am.
know?
Sure, ma'am.
So that's
Thank
what
you.
I would like to say. So it's a good, wonderful work. So anybody else for any
Thank you for
question?
the suggestion. Thank you, ma'am. What was the first question? Cost? Yeah. I see the cost is basically with the instrument, purchase of the instrument. So we are just trying at, presently I am working at GMCH Chandigarh. So we have tried a lot, and now we are in collaboration with Department of Neurology. One of my project is at PGI MAR also, and at the Apex Institute, there is no problem for getting of the instrument, and at the peripheral, yes, we have to go through a very long process, but once the instrument is there, there is no further cost. Just you need that that ECG gel for that ultrasound probe, that's it, and that basic electrical connections. Otherwise, there is no cost. And if you are there for induction of some cerebrovascular reactivity, such as for breath holding, you didn't require anything else. But if you are intended to use that some fixed concentration of carbon dioxide or these things, so for that, your basic setup is required. After then, maintenance cost is minimal. Once the setup is there, maintenance cost is minimal. And for that impending thing, yes, all those, we all know that lifestyle diseases are there, ultimately resulting in either the cardiovascular complications or the cerebrovascular stroke or anything. Yeah, that's why. So that's the role, that's the place where the role of physiologists are there, yes. We have to dig that out thing, na, ki how to screen the patient, how to get to know about that impending complications and these things. Yes, ma'am. Nicely said. Okay, thank you. Thank you.
Wow, very informative session. And now I would like to request Dr. Jarial, Professor of Department of Physiology AIMS, to facilitate Dr. Aarti Sood Mahajan, ma'am, please. Yeah. And Dr. Shivani, would you like to, please? Yeah, ma'am, please. Just thank you, not thank you for your presence, for inspiration, for being here. And now I think it's the lunch time, so all can go and have a lunch. yeah, sorry. Uh, yeah, sorry. Ma'am, please come on the stage to facilitate our speakers also. Sorry, that's fine. Our, our first speaker is Dr. Shival Srivastava. Dr. Kiran Prakash, ma'am. And Dr. Manpreet Kaur from VMMC. Thank you. Now we can go for lunch, I think. Sorry.
our institute, ESIC Medical College, Faridabad. With deep gratitude,
नहीं, ये अंजू ने
अंजू ने दिया है, प्रवीणा ने तुम्हें और कुछ नहीं दिया?
कुछ नहीं दिया। हाँ मैम। So good afternoon one and all, and welcome back in post-lunch session, that is plenary lecture 3 on antibiotic stewardship program, which is shifted from Dhanvantri Hall to this Shushrut Hall. And, and now I invite our respected chairperson of the plenary lecture 3, Dr. C.D. Tripathi from JIMS Greater Noida, and he is currently professor and head of Department of Pharmacology. He has been faculty in various prestigious medical institutions like VMMC, LHMC, MAMC, and JIPMA. A person of extensive academic background, Dr. Tripathi is president of Indian Society for Rational Pharmacotherapeutics, member of executive body of Government of India for National Anti-Doping Agency, member of committee constituted by Ministry of Health and Family Welfare for evaluation of fixed dose combinations and investigational new drugs. For his research work, he is awarded by PP Surya Kumari and OD Gulati Award for research by Indian Pharmacological Society. Also Gujral and Bhargava Oration, KGMU 2014. He is trained by US FDA and CDSCO for GCP and clinical research inspection. Dr. Tripathi has supervised about 20 MD pharmacology, 4 PhD students, and published around 70 research papers in national and international journals. And not only this, he authored 3 books by his name. So our next chairperson is Dr. H.S. Rehan. He is currently a director and professor and head of Department of Pharmacology at Lady Hardinge Medical College. He is also visiting professor, University of Durham, UK. He served as subject expert to several national and international professional bodies, namely CDSCO, ICMR, Central Insecticide Board, RC, WHO, and an elite member of several health programs in India. He had done parallel research work, being a pioneer in generating organ from autogenous stem cell. Dr. Rehan is coordinator, pharmacovigilance and Vigilance program of India. He published 110 original research paper in national and international journals of repute. develop consensus guideline for the management of dyslipidemia in Indians, awarded Commonwealth Fellowship, UK, and several prizes for research and publication. Now I invited our chairperson to introduce our speaker. Please. It's not in display. Actually ये ना धन्वंतरी सेशन का था तो हमारे पास इसकी पीपीटी नहीं है.
Dr. N.C. Gupta, basically the US professor and head at Pandit V.T. Sharma PGIMS and also director of that institute, subordinate and joining again here as the
Mic off है.
Hello. Oh, sorry. I will repeat again. Dr. Gupta presently is at World Medical College, Jhajjar. But before that, he was head of the pharmacology at PGI Rohtak and also director of that institute. And apart from that, he is the active member of Drug Advisory Committee of Haryana government. And he is a member of the Quality Review Panel of the National Pharmacovigilance Program of Government of India, Fellowship of International Medical Science Academy, and is a recipient of Bharat Jyoti Award by India International Friendship Society, and so many other prestigious awards. And he has been Distinguished Service Award by the Sri Baba Mastanath Group of Institution at Rohtak, and Best Teacher Award by number of other societies. And till now he has published more than 150 paper in national and international journal. And apart from that, Dr. Gupta is a known distinguished academician and administrator. And I hope that the today lecture, which is about the talk about the antibiotic stewardship program, he has the wide knowledge about that field, and what is more important that although in academic institutions we talk about a lot of antibiotic stewardship program, but sometime I have seen a number of administrators, what happens when their antibiotic is going to expire in hospital, they will just direct write this antibiotic. After 6 months, other antibiotic is going to expire, and then again they will send a circular that please write this antibiotic more. So this whole program of your stewardship get, but because he has the experience of both administrator and the as a faculty member, and he will be putting more, he will enlighten us about all these issues. Thank you.
Sir,
Dr.
please
Gupta.
come, sir. So you have PPT, sir? Should I start it? So, this is the power. Yes, sir, this is the power, and you can change it from here also. And there is a pointer. Think pointer, I don't know actually.
Well, good afternoon to all of you. I think I'm in a very august company of two gentlemen here, the chairmen, and they themselves are the legends as far as pharmacology is concerned. And then I have my friend and again a pharmacologist par excellence, Dr. Rakesh Dikshit, Arun, Monica from my old alma mater. See, when we were having lunch, I was feeling a little happy that the hall was crowded of the people who were taking food there. But then we had a discussion that how many people from this hall will be coming to listen to the talk. And we had our suspicions. So your worst suspicions, they always come out true. That is the famous adage. So now we have total 8 people. And if the chairpersons, they allow me, in fact, we can have a one-to-one committee meeting type rather than than having a lecture. But since I have been given this responsibility, but then I have a very plus point also. I don't know about many people, but I have a clinician here. The ENT specialist, Dr. Raya, is also sitting. And normally what happens is when we talk of such things, the pharmacologist, they speak, the pharmacologist will listen, and they go home. Neither of them is the prescriber. All right. So basically it falls on the deaf ears. So that is why antibiotic resistance, that is why it's such a big problem, because clinicians never listen. Pharmacologists listen, they don't prescribe, so that is why the problem. Same is true of pharmacovigilance. It has come up in a better way, little bit, because of the efforts again, but then clinicians there also somehow they are not able to participate. So I think that's why I'm very happy that at least I have one person whom I can really interact as far as this program is concerned. All right. Okay, fine. All right, so that makes me a little more happy. uh, Talking about antimicrobial stewardship program, I think there's no idea giving some details of this program until unless we know the background. And that background is why such programs are needed. So until unless we realize that why it is needed, I will be failing in my duty. So I think we need to first go into antimicrobial resistance, which is not a problem of a state, which is not problem of a country, it is problem of the globe, and a very serious one at that. So I would like to show you the impact of antimicrobial resistance, so that first we need to be convinced that we need to do something. And then we come to that one of the things which can be done. So this AMR is a natural phenomena, though, but the drivers of both its development and spread are man-made. So it is the man who is responsible for this. And out of man also, when I say it's a generalization, it is the doctors themselves who have played a very major role as far as development of antimicrobial resistance is concerned. And the first reason is the most important one: misuse and overuse of antimicrobials in humans, in animals, in plants. And then, of course, we have not been able to match the availability of the vaccines, superior diagnostics, and appropriate treatment. And when I say that, there is a big innovation gap. We talk of super bugs, all right, there are many now, but we do not have any super antibiotics. So there is a huge gap that we do not have the appropriate treatments for these. There is lack of access of basic amenities like clean water, sanitation, and hygiene that further complicates the scenario. We are very poor at infection prevention and control. And in fact, if I can say that with a heavy heart, not many people are aware that there is something like antibiotic policy of India. I am sure that there are not many people who know that India is one of the signatories in the world to the NPA, that is National Antibiotic Plan, which is in place. Hardly anyone is aware. Any student, any residents, any faculty I talk to, they are not aware of such programs. And every hospital has a hospital infection control committee, but I have not seen them having a meeting. If at all they have a meeting, there are no minutes. If at all there are minutes, they are never circulated. So nobody is doing the job. So that is what culminates into poor infection prevention and control. Transmission of resistant pathogen through the food chain, that's another common problem. And then the waste management system in India. I mean, you just, for a glimpse, you can go to river Yamuna in Delhi and you will know how good is the waste management system. So these are some of the problem areas which have contributed to this. Now WHO has some strategies, because WHO has been working without fail in a very sustainable manner, I would say, and they are coming out with the policies. So one of the policies they have made is National AMR Action Plan, of which I am talking, that India also is a signatory to this. We have National Antibiotic Plan, and there are 148 countries who are signatory to this plan. We have been celebrating now Antimicrobial Awareness Week campaign in November every year, and most of the good institutes, I would say, they are celebrating this week, where the students can make some posters, where the faculty will present the lectures, will discover the current surveillance patterns, the gaps, and what are the options for us to do. And then, of course, there is a global program now with the short name GLASS. That GLASS stands for Global Antimicrobial Resistance and Use Surveillance System. This is basically getting converted into a database, which is a global database, which will help you in telling that what are the trouble organisms, what drugs are effective against them, what drugs are failing against them. So this is an international program. And then, of course, there is a tripartite AMR country self-assessment survey with a short name TRACCS, which is conducted, and it's reporting annually. So these are some of the important strategies and initiatives by WHO. Now, this is worth getting, we should have fear of this kind of thing, In 2019, a study has been conducted across 204 countries involving, it is one of the largest, I would say, 471 million patients' records have been collected, and this has been recently published in a journal not less than Lancet 2022, and see the data. There were two counterfactuals, the deaths which possibly can be attributable to MAR, but our main concern is the deaths which actually happened because of AMR. So total deaths associated with bacterial AMR, look at the figures, 5 million, 50 lakh. And then out of this 1.5 million happened only to lower UTI. Staph aureus related deaths were more than 1 lakh. And 6 commonest pathogens which were encountered in these million cases were E. coli, Staph aureus, Strep pneumoniae, Acinetobacter, Klebsiella pneumoniae, and Pseudomonas. So these are found to be the 6 commonest organisms. All right, going a little further, look at this. This should be an eye-opener. It is now presumed that if we continue like this, what we are doing, by the year 2050, major deaths, they will not be because of cancers. The major deaths not be because of non-communicable diseases. Major deaths and the major killer would be the antimicrobial resistant infections, and they could touch the figure of 10 million, which is already 5 million. It could be doubled in next 20 years or so if we don't get awakened. All right, so sometimes we understand the language of money more importantly. So we need to see the financial impact. It has been estimated that managing these infections is going to need, look at this sum, $14.2 trillion. I just applied little maths today, and I started calculating how many zeros I should put in front of this. It turned out to be, write 142 and put 11 zeros in front of it. That is the figure I'm talking of, and this is dollars. Multiplied by 75, that makes it rupees, and this is 6% of the GDP of the world. Imagine if we could control somehow the antimicrobial resistance, what is the amount of money available to us which can be spent in welfare activities of whole of the world. All right, this is mind-boggling figure, and in fact there is a serious risk now that we may return to pre-antibiotic era, like where we started, back to 22 situation, right? That is what we are specifically fearing. Why we are fearing this? I think needless to say, if you ask a question these days, that there is a war. There is a war between man and bacteria. Then the question always asked is, who is winning the war? Do you know the answer? So, we are winning small battles here and there, all right, but if we talk of the whole of the war, we are badly losing. And if this continues, जो छोटी-छोटी battles हम जीत रहे हैं, even we are going to lose those battles as well. So scenario is dismal. It is a very kind of gloomy, but then we have to search that ray of hope. And that ray of hope, I would like to suggest few strategies. Now this is another area these days. We have recently gone through COVID, and everyone could calculate that if COVID is going on in UK and US, we are only 3 weeks away from this. In 3 weeks, we are all going to get infected, and this is what has happened 3 times, not once, and we are waiting for the 4th one to happen now. So why is this so? Look this data. 1 billion people cross through the international borders each year. 1 billion people, they are crossing the borders. And out of this 350 million travelers, they arrive in United States through more than 300 points of entry. So with this kind of journey and transport facilities, this takes no time. That there is an epidemic in anywhere in the world, in no time it becomes a global epidemic. That's what happened to Corona. And look at this. This is new CDC data. More than half of the antibiotic prescribing for selected events in hospitals was not consistent with recommended prescribing practices. So we are violating the protocols everywhere. Our choice of antimicrobials for a given organism has been relatively very poor. 79% of patients with community-acquired pneumonia were wrongly treated. 77% of patients with UTIs, they also got the inappropriate antimicrobials. So that is the quantum of mismatch between the bacterial organisms and the antimicrobials being prescribed. So these are some of the trouble areas which will come out of this. Antibiotic resistant infections, they threaten modern medicine, you know. Sepsis treatment, 1.7 million patients, they get treatment. Surgery, cesarean section, 1.2 million. This is US data. But please understand, Indian data is going to be much worse and much larger than this, okay? So chronic conditions like diabetes, 30 million people. Now, in fact, as far as India is concerned, we call it now diabetes capital of the world, all right? Similarly, organ transplants, dialysis for advanced kidney disease, cancer care. Why I'm showing these? These all areas are going to get complicated because antimicrobials are not working. And this is what is getting affected. Interconnected threat of antibiotic resistance, which goes beyond humans, it goes to animals, and above all, it goes to the environment also. So these are the now, before I go into the stewardship program, I think I quickly wanted deliberately that I should tell you what NAP is. NAP is now, full name is NAP-AMR. NAP is National Action Plan for Antimicrobial Resistance, and India is playing a wonderful major role in this because we are not only signatory, we have told the General Medical Assembly that we will take lead as far as this program is concerned, okay? So there are different strategies which are there. Priority strategy number 1 is improve awareness and understanding of AMR through effective communication, education, and training, okay? Strategy 2 is strengthen the knowledge and evidence through antimicrobial surveillance so that we know which are the trouble organisms. Priority number 3 is reduce the incidence of infection through effective infection prevention and control, which I was talking to you, it's totally lacking. And then strategy number 4, which is today's concern, optimize the use of antimicrobial agents in all sectors. This is what relates to the stewardship program, which I'll be talking in details. Strategic priority number 5 is promote investments and innovations for AMR activities. And priority 6 is strengthen India's leadership on AMR by means of collaboration at international, national, and subnational levels. So these are the 6 strategies of Government of India, NAP, which if converted, I'm sure they will make the difference. So with this background, now I switch over to, for what I have been invited today, talking of what this antimicrobial stewardship program is. So first let us understand the definition of the program. Antimicrobial stewardship is the systematic effort to educate and persuade prescribers of antimicrobial drugs to follow evidence-based prescribing in order to stem antibiotic overuse and thus the antimicrobial resistance. Because AMR is directly connected with the overuse, you know. So if we can reduce the use of the antimicrobials, we can, some extent, we can reduce the AMR. And why it's a problem area? Because in fact, we have been pumping in antibiotics day in, day out for treating those infections which do not need antibiotics. We are treating upper respiratory catarrh. We are treating diarrheas. For every fever, we immediately start with antibiotics. And in fact, these days, the unfortunate thing is, doctor, he doesn't have to wait. He doesn't have to prescribe. You know, people are doing self-treatment. And this COVID has converted every single human into a doctor. In fact, commoners have become doctors. डॉक्टर से पूछेंगे कि कोरोना का क्या करें, वो कहते हैं कि यार मैं इसका स्पेशलिस्ट नहीं हूं, आप किसी ऐसे बंदे से बात करो जिसका कोरोना का एक्सपोजर है. जो कॉमन मैन है वो स्टेरॉयड भी बताता है, वो टेट्रासाइक्लिन भी बताता है, वो रेमडेसिविर भी बताता है, और कुछ जो थोड़े पढ़े लिखे हैं वो तो टॉसिलिजुमैब भी बता देते हैं कि ये भी ले सकते हैं आप. आई मीन दिस इज द काइंड ऑफ सिनेरियो where everyone is ending up self-treating. So no wonder they have already taken amoxicillin, they have already taken doxycycline. So these are the problem areas. So this overuse, if it is curtailed, so this program is basically a voluntary, it's a kind of effort so that we can educate. We can tell people that they should try to use antibiotics only in specific situations. They should be guided by the evidence-based clinical judgment, and that is how this program will lead on to these three outcomes. So these strategies are basically to improve the use of antimicrobial medication. With what goal? Goal number one is we want to improve the patient's health outcomes. Second is we want to reduce the antibiotic resistance. And third is decrease the unnecessary costs. Because more use of antibiotics, more resistance, more need of newer drugs. And I'm sure we have lots of pharmacologists here. A very simple equation for one successful drug development is that $1 billion, 9 to 10 years of time, that is the kind of intense kind of research requirements, the resource intensive, So this is big expenditure, So if we can avoid AMR, we can reduce the numbers of the drugs needed, and we can save lots and lots of money in the process. So to give the little more details, improve patient outcomes in terms of both patient safety and efficacy, reduce the ADRs, Clostridium difficile induced diarrhea and invasive candidiasis, which are the common biological complications of antibiotic treatment. We guard the patient's microbiota, gut flora, respiratory tract flora, urogenital tract flora, and skin flora, because when we give antibiotics, we try to disturb the whole non-pathogenic bacteria of the body, which are the defensive ones, So we, in fact, are ourselves breaking body's own defense mechanisms, And then, of course, we want to slow the increase in this AMR rate, and we want to prevent the unforeseen environmental degradation, and we want to avoid the adverse effects of altering biotas and microbiotas of the environment. So who are the participants? So this may be a little debatable. Institution to institution, this may vary, but I am giving you a generalized constitution of an antibiotic stewardship committee. Any good hospital should have a stewardship committee, of which there are some core members. The most important member would be prescriber. And out of prescriber also, specifically the ones who are responsible for treating infectious diseases. All right? So any clinician who is treating some kind of infection automatically should be a member, and few of the clinicians, they can be top members of the committee. Then, of course, since we are talking of the surveillance patterns, microbiologist is the person who will recommend, who is going to recommend the newer antimicrobials and their pharmacology, etc., their safety, efficacy issues. It would be a clinical pharmacologist, and of course, it will not be completed till the time there is a pharmacist who is going to maintain the stores and the requisitions. There has to be a quality improvement specialist, there has to be a hospital administrator, and there should be a hospital epidemiologist, and at least one member of the hospital infection control committee. So these people together constitute what you call as a stewardship committee, who will make the necessary recommendations. So what is the baseline assessment? So parts of the baseline assessment are, first, the committee should measure the baseline antimicrobial use, their dosing patterns, the kind of durations for which they are being given, what are the costs, and the user patterns. See, the problem is, like I'm sure all of you have gone through Ramayana and Mahabharata. There used to be war, Ravan ki Ram ki bhi hui thi, Mahabharata mein bhi hui thi. तो पहले क्या होता था? पहले थोड़ा तलवार से लड़ते थे, फिर कोई अग्निबाण आता था, फिर उससे कोई सीरियस आता था, लास्ट में ब्रह्मास्त्र निकालते थे कि अब ये सब कुछ उजाड़ के आएगा. All right? So this pattern has changed. हम मीरोपेनम पहले देते हैं, एमॉक्सिसिलिन बाद में देते हैं, तो ब्रह्मास्त्र सबसे पहले चला देते हैं, और ब्रह्मास्त्र जब जाता था तो तबाही मचा के वापस आता था. That is what is happening to us. We have simply forgotten the simpler antimicrobial. We are all the time going to the high-end antimicrobial, चाहे वो ICU है, वो seriously, there is a life-threatening kind of sepsis where you'll be using those drugs. So we are using them right in OPD patients. So this is something which is becoming our undoing. और फिर करते क्या है? जैसे होता है ना, कई बार आप कुछ गलत काम करते भी हो, फिर आपको डर भी लगता है। डर लगता है तो आप दब के करते हो, तो थोड़ा थोड़ा करते हो। अब ऐसे ही हम कर रहे हैं कि देंगे मिरोपेरम, देंगे आधी डोज में, देना चाहिए था 7 दिन के लिए, देंगे 3 दिन के लिए। So this is how we are doubly spoiling the game. All right. So one, our choice is not appropriate. Once we make a strong choice, we want to use it sparingly. डरते हुए यूज करते हैं उसको. So it doesn't work at all. And in no time, a life-saving drug is converted into a redundant drug. That's what we are doing. And then, of course, they should study the microbial isolates, their susceptibilities, and the trends thereof, and they should identify the clinician indications for the prescriptions. So these are some of the core areas which this committee need to consider before they implement the program. So these days things have become simple. Everything is having the IT angle these days. So even stewardship program also has a IT angle to this. IT people, they have already developed the software program which can successfully run a stewardship program. There are many, but I have taken some example. Feed Steward, Theradox, Sentry 7, Vigilance, Medici, APSS Plus. These are some of the used programs which are software programs for running an antimicrobial stewardship program. So what are the interventions which are needed for the antimicrobial prescribing? See, the day-to-day work of the core AMS members is to screen patients' medical records. Why would they like to go through the medical records? They want to know appropriate antimicrobial choice. Was it based on susceptibility? What was the appropriate dose given? Was there an appropriate dosing interval? Was a drug-drug interaction ruled out? Was there appropriate de-escalation of the antimicrobials post-culture sensitivity test? And appropriate route of administration was there to start with? And if needed, did the clinician go for the switch therapy? Switch therapy is going from IV to oral use. And that should always be done actually. When a patient is serious, we always end up starting with intravenous infusions or whatever. But then at the earliest opportunity when it is permissible that we can switch the oral therapy, we should always do it. So all these points, they should be considered. So what are the AMS outcomes to measure? So these are the things they would like to find out by recording all these things. What are the annual pharmacy acquisition costs? Costs are always important. Whether we attach some importance to this or not, every hospital needs lots and lots of money to be run on a daily basis. So costs are always important. How many antibiotic days they have to be calculated? Identifying the drug-bug mismatches, this is the most major problem. IV to oral conversion, optimal dosing, stopping the redundant therapy. See, this also is important. We have started with the antibiotic, patient is not improving, investigation is not improving, still the drug is continuing. Culture sensitivity report, either भेजी नहीं, भेजी थी तो आई नहीं, आई थी तो पढ़ी नहीं, पढ़ी थी तो change किया नहीं. I mean, these are the things which are being done, so it becomes redundant again. Reducing the adverse events, and then of course, do we really comply with the ASP recommendations? सबसे बड़ी प्रॉब्लम जो है बाद में मैं एंड में डिस्कस करूंगा, लेकिन अभी भी कह देता हूं. फॉर सच ए प्रोग्राम देयर इज ऑलवेज ए चैलेंज. चैलेंज क्यों है? वर्ल्ड आज की डेट में 2 साल के बच्चे से भी आप पूछोगे तो वो भी चाहता है कि मैं जो भी करूंगा अपनी मर्जी से करूंगा. एवरीवन नीड्स ऑटोनॉमी. नोबडी वांट्स एडवाइस, नोबडी वांट्स अ लेक्चर. तो ये 2 साल का बच्चा ऐसे कर सकता है, तो जो सबसे समझदार क्लिनिशियन है वो ये ऐसा क्यों नहीं कर सकता? क्लिनिशियन को यदि फार्माकोलॉजिस्ट बताए या माइक्रोबायोलॉजिस्ट बताए कि आपको ऐसे करना है और आपको ये एंटीबायोटिक यूज नहीं करना चाहिए, आपको ये वाला देना चाहिए, it is kind of reactionary phenomena which sets in because most of the people they want autonomy on this. आपको कोई बताए कि आपको ये दवाई लिखनी है या नहीं लिखनी है, this is the challenge for this program कि आप स्टीवर्डशिप में बताएंगे कि क्या देना चाहिए, कोई सुनेगा नहीं. So that is the undoing of this program to begin with. All right. So there are 2 approaches to apply the stewardship program. One which is known as front end approach और जिसको हम बोलते हैं प्री प्रिस्क्रिप्शन अप्रोच. सिंपल वर्ड्स में इसको एक्सप्लेन करूं तो इसका मतलब मेरे पास हॉस्पिटल में 60 एंटीबायोटिक्स हैं मान लीजिए. उन 60 में से कम 10 एंटीबायोटिक ऐसे होंगे जो टॉप एंड एंटीबायोटिक्स हैं, उनके लिए हम रिस्ट्रिक्टिव पॉलिसी यूज करेंगे। उनका यूज सिर्फ वही क्लिनिशियन करेगा हु इज ऑथराइज्ड टू डू इट। दूसरा क्लिनिशियन करेगा तो उसको स्टीवर्डशिप कमेटी से परमिशन लेना होगा डॉक्यूमेंट भेज के कि मेरा ये पेशेंट है, उसको ये प्रॉब्लम है, दिस इज द कल्चर सेंसिटिविटी और दिस इज माय empirical best guess treatment basis, please allow me to use this antibiotic. Otherwise वो clinician इस antibiotic को use नहीं कर पाएगा। This is the pre-prescription, that's why we call it restrictive policy. You know, this is front-end approach. The advantages of this front-end approach is that we'll be targeting only specific antimicrobial for specific indication, so this will make the use more rational. All right. Antimicrobials can be approved for a specific duration, thereby prompting review after culture data so that we can change it. And that, of course, it will lead on to significant reductions in expenditure. लेकिन इसका एक साइड इफेक्ट भी होता है, जैसे फार्माकोलॉजी में हर ड्रग का साइड इफेक्ट होता है, हर स्ट्रेटजी एक साइड इफेक्ट होता है। साइड इफेक्ट क्या है कि हमने 10 एंटीबायोटिक तो रिस्ट्रिक्ट कर दिए थे, उनके लिए तो प्रॉब्लम हो गई, बाकी के 50 तो खुले अवेलेबल है ना, फिर वो लोग उन 50 को लेफ्ट एंड राइट लिखते हैं। सो दैट बिकम्स दी side effect of this front end strategy. Then there is another one, that is back end strategy. As the name suggests, it's a post prescription approach to stewardship. इसमें क्या करेंगे? This is not retrospective कि restrictive पहले ही हमने एक limitation लगा दिया था, इसमें limitation नहीं है, इसमें clinician कुछ भी यूज करे जो उसका मन है, but हम क्या करेंगे, हम prospective review करेंगे, feedback लेंगे, current antibiotic orders को देखेंगे, algorithms या protocols follow हो रहे हैं कि नहीं हो रहे, continued, adjustment, change, discontinued therapy, everything will be studied prospectively. So we'll have a kind of feedback, and this feedback will be given to the clinician so that things can improve subsequently. So there can be either post-prescription approach or there can be pre-prescription approach. इसकी क्या advantages हैं? The back-end approach, it will decrease the antimicrobial use, it will decrease number of prescriptions of antimicrobials, and this will improve clinician satisfaction because you are not applying any restriction for the drugs anyway on the you know. So this is just to show the brief. All right, so what are the techniques to optimize antimicrobial use in the hospital? So for a comprehensive antibiotic stewardship program in a hospital, these are some of the do's. We should have some kind of formulary restriction. We should have defined treatment algorithms, specifically in the serious areas, like ICUs. ICUs, they always should have antimicrobial protocols. There should be clear-cut clinical guidelines. We should constantly educate all the concerned, and we must talk of the PK/PD basis of dose optimization. This is another thing which is not very well understood. But present day modern clinicians who have been trained in this, they have already started talking of this thing. This makes me very, very happy. Every good clinician these days, before prescribing, he wants to know the PK/PD basis of drug which he wants to prescribe. And this is one of the ray of hope in the horizon, which I can say. So for a comprehensive ASP in hospital, what else can be done? We can have computer-assisted decision support programs, which I have given to you already. We must always go from intravenous to oral switch program. We should go for antibiotic dosing programs. And of course, this is another term which is constantly being talked of these days, antibiotic rotation or recycling. This has also worked a lot. All right, we decide today that our hospital from tomorrow will not use a particular antibiotic for a duration of say 6 months, 1 year, 2 years sometime. All right, because a lot of resistance is coming to this. It has been seen that after 1 year, when you start prescribing it again, the sensitivity patterns have come back. So that is what the rotation policy means. So many hospitals, specifically in the West, they are already exercising with these rotation policies. So what are the steps to be taken when we are implementing this program? Understand the problem pathogen and the antimicrobial use at your institution. Now why this institution, what is important here? Even in a country like India, if you go to different hospitals, you know, you will find
their antimicrobial resistance patterns are different from institution to institution. Their antibiotic choices are different. Their susceptibilities are different. So that means if we have a stewardship program at ESCIC college, it basically is meant for this college only, because this program should be based upon the surveillance patterns of this hospital. Assess your current resources, कि ये बिल्कुल सिंपल सी बात है कि जब आप मार्केट में भी पैसा खर्चने जाते हैं तो आपके बटुए का ख्याल तो आपको होना चाहिए. What kind of money you have, all right? With 5,000 rupees in your pocket, you cannot go to DLF Emporio. Their coffee costs you 750 rupees a cup, all right? So determine your priority areas and plan for intervention. Engage the hospital leaders, because without the leaders, no plan will ever be successful. Then make a plan, put the plan into action, and if you have put the plan into action, you should be ready for the feedback and auditing and accountability. This is always important. Without accountability, nothing works, you know. So remember that the most successful plans, they incorporate educational outreach and physician feedback. All right, so this should be based upon that only. So coming in the end, so provide feedback and continuing education. We must survey prescriber knowledge about the antibiotics, provide targeted education, give them the details of empiric treatment versus culture directed treatment, assist in making duration more visible, decreasing diagnostic uncertainty by appropriate testing, including the rapid diagnostic tests. Now this has become the important need of the day, that everywhere we have to start some empirical treatment. Empirical treatment के लिए generally लोगों का मानना ये है कि हम एक हिंदी में मुहावरा यूज करते हैं, अंधेरे में तीर मारना. अंधेरे में तीर फेंका, लग भी सकता है, ये भी हो सकता है कि साथ खड़े बंदे के माथे में जा सकता है. And we have been causing lot of damage due to this. तो अंधेरे में तीर भी मारना है तो थोड़ा कुछ ऐसा जुगाड़ होना चाहिए कि निशाने पे लगे. वो निशाने पे तब लगेगा जब थोड़ा सा रैपिड टारगेट हो हमारे पास. हमारे पास बड़े सारे टेस्ट ऐसे हम कर सकते हैं. आप क्लिनिकली सस्पेक्ट कर सकते हो, आप हिस्ट्री ऑफ कॉन्टैक्ट ले सकते हो, हिस्ट्री ऑफ जर्नी ले सकते हो, हिस्ट्री ऑफ प्रीवियस सेंसिटिव रिपोर्ट ले सकते हो, ग्रैम स्टेन कर सकते हो, एलाइजा कर सकते हो, पीसीआर कर सकते हो. These are all the tests you will get to report from minutes to hours. कल्चर सेंसिटिव बहुत घंटे वाला है, एंड उसमें भी चांस है बड़ी वाली कल्चर आता ही नहीं है. आता है तो सेंसिटिविटी नहीं आती है, सेंसिटिविटी आता है तो आपकी फार्मेसी में ड्रग अवेलेबल नहीं है. ऑलराइट, so there can be so much of mismatch, you know. But this thing can be a savior, that we should be able to make some kind of diagnosis even for empirical treatment. And that is why another name for empirical treatment is best guess treatment. ये नहीं है कि कुछ भी कर दिया, कुछ भी दे दिया कि दे दो. और लोगों की जनरली सेफ अप्रोच क्या है कि पहला काम ये करो, चाहे पैटर्न कहते नहीं कहते, टेट्रासाइक्लिन दे दो. टेट्रासाइक्लिन क्यों दे दो? स्पेक्ट्रम बहुत ब्रॉड है. या ऐसा करो कि 3 एंटीबायोटिक इकट्ठे शुरू कर दो, कोई तो लगेगा. And this is the kind of absolute non-scientific approach which we adopt. And it's not that this program doesn't work. Just 1 minute. This possibly may be second last. So this program works a lot. Some studies have been done. This is one I have found, one of the latest studies. Look at where we started. With this antimicrobial stewardship program in place, there was a definite reduction in the antibiotics being prescribed. Almost 18 से आप देखिए 5 पे नंबर आ गया. So this is how the percentages, they can be influenced. So if a institution or a country or world, we can follow this stewardship program, we definitely can reduce the number of antimicrobials prescribed. So coming to the end of it, rather than putting it in words, in conclusions also I have put a figure. So this figure gives you the whole thing of what we have talked already. So core elements and features of antimicrobial steward programship are, ये सब कुछ करना है. These are all the doables. Enhance the infection control. Control the source of infection. Use antibiotics when needed. Choose antibiotic based upon local susceptibility patterns. Optimize the dose and route. Reassess the treatment when needed, specifically after the culture report is available. Monitor the antibiotic consumption. Educate the staff. Support and having interdisciplinary collaboratory approach. And then most importantly, doing de-escalation following culture sensitivity report. So these are all the important ingredients of the stewardship program. And if you do it all, these are definitely going to be the benefits which you're going to reap. Unaltered outcomes from the conventional therapy, that means good efficacy. You will have reduced antimicrobial resistance, which is the concern, major concern right now. You will be decreasing the antibiotic-related adverse event, and if you do it all, you will be reducing the costs markedly. So this is the summary of my presentation, that if you do all these things and you have a successful antibiotic stewardship program in your institution, you can really work wonders with this, and we can help reducing that AMR, which is becoming such a big concern. So with this, I finish my talk, and I've shown this picture specifically where I warned that we are waiting for the new dawn. So this is a sunrise. So we hope that with some kind of education and training, with having such kind of programs, by being aware of the resistance patterns, by developing the new antimicrobials and approaches, we people still can win that war which we are losing right now. So I wish all the clinicians good antibiotic prescribing practices. Just 10 seconds on this. These days it is very prevalent, sir. Dr. Hansa will agree with me, Dr. Patil. We want to write everything good. Good manufacturing practices, good pharmacovigilance practices, good clinical practices, good research practices, good ethical practices. So I thought I'll coin this stuff. Good antibiotic prescribing practices. And I say there are gaps in gaps. First gap means the lacuna, deficiency. Second gap is this. So let us all be together and fill the gaps in gaps. All right? If we can do that, we are going to do wonders. Thank you so much.
Thank you, Dr. Wonderful, informative and lucid presentation as usual. You covered almost every aspect of the antibiotic policy and the antibiotic stewardship, which we have been listening from for a very long time, and probably it has made an effect also at one of the other places. So, few comments from my side, and then we leave the house open for discussion. Pharmacologist should not be blamed. Pharmacologist is doing his job. His job is to design a good policy. If he really design a policy, implementation is not his part. It's the administration. If they want, if they have an intent, policy will be implemented. I cannot fire a clinician, but my administrator can fire a clinician.
Yes.
So that is the thing, and pharmacologists have done wonderful job in the past, and still they are doing and designing a good antibiotic policy. And most of the, basically, I feel antibiotic, they work like an anxiolytic. When patient takes antibiotics, he is at ease. When doctor give antibiotic, he is at ease. So antibiotic work like an anxiolytic for both the stakeholders. So bacteria came first on this earth. They have a more rights. They have a better laboratories and science. They know how to live with others, and human doesn't know how to live with others. We are living with animals now. COVID has affected us. It's an organism for animal. It's affecting us because we have interfered with it. So the symbiosis which is there, it is a problem because animal zoonosis will not occur to human until and unless bacteria or a virus change itself to affect us, and which he has successfully done that. So we need to behave with bacteria and forget about the antibiotics. If we really behave with them, we won't be needing any antibiotic, I believe. So with this, we leave house open for discussion. If there is one or two questions from audience, we will have Dr.
Overuse is one of the cause for this. Underuse also.
Yeah. That's what I said. That you use them half-heartedly.
That is, I think, homeopathic group.
And this is an example. See, we talk of LDR, we talk of XDR. If you ask me, I propose, even if nobody likes it, बीच में सर आपको याद होगा, we cut short the duration of the tuberculosis treatment. We made it intermittent regime for 6 months. You know, ये उसके बाद MDR आना शुरू होगा. So I think having such kind of strategies without the real evidence, that is what creates a problem. You're very right. Overuse is one angle of the problem here. Underuse is the equally important problem.
Sir, I just wanted to understand taking whatever I want, until when we take that also into their program, don't you feel, I mean, it might be just on papers?
Yes, correct, sir. I already said that in India this is a problem. See, antibiotics is one of the important classes of drugs which are absolutely strictly under Schedule H. They are prescription only drug. But tell me, leave apart the antibiotics. अभी मार्केट में चलते हैं इकट्ठे मॉर्फिन मांगेंगे, केमिस्ट मॉर्फिन भी डिस्पेंस कर देगा। आप उससे कंपोज मांगिए, कंपोज डाल देगा। तो ऐसे बंदे से एंटीबायोटिक मांग लो, आप ढेर एक टन एंटीबायोटिक भी एंटीबायोटिक सब्स्टिट्यूट कर लेगा बिना प्रिस्क्रिप्शन के। एंड देन लुक एट दी टीवी, सबसे ज्यादा एड इस वक्त जो आ रही हैं वो इंटरनेट फार्मेसीज की आ रही हैं, 20% डिस्काउंट। एवरीवन इज आस्किंग फॉर मेडिसिन लेफ्ट एंड राइट बिकॉज 20% डिस्काउंट है। उनको कौन मॉनिटर कर रहा है, कौन उनको देख रहा है? अब मुझे बताओ ना, डायबिटीज की मेटफॉर्मिन मान लो आपने फार्मेसी से मंगा ली, तो क्या मेटफॉर्मिन से डायबिटीज ठीक होती है क्या? उसको कौन बताएगा कि तुझे खाना कैसे खाना है? उसको कौन बताएगा कि तुझे एक्सरसाइज कैसे करनी है? उसकी सेफ्टी कौन मॉनिटर करेगा? सो दिस इंटरनेट प्रिस्क्रिप्शन, internet based treatments, you know, they are going to, you're very right that everyone has become a self prescriber. And in our country, we are proud of our country, but then there are certain things which we feel so bad about. Every drug is a OTC drug in India. We don't have a policy for OTC drug in India. OTC पढ़ाते हैं बच्चों को, there is nothing official about OTC status. इंडिया में ये मानते चलते हैं कि जो ड्रग प्रिस्क्रिप्शन only नहीं है वो OTC ही होगी. So this is how we believe. And everyone is ready to dispense anything. आज तक मैंने कभी जिंदगी में प्रिस्क्रिप्शन देके दवाई कभी भी नहीं ली। हमें तो चलो ये एक डॉक्टर समझ के दे देते हैं कि तू खुद डॉक्टर है, जो डॉक्टर नहीं है उसको भेज दो, उससे मंगवा लो जो मर्जी है। तो जब कोई सैंक्टिटी है ही नहीं, we have regulations are beautifully placed, but implementation of the law, implementation of the regulation, we are the weakest country.
सर फरीदाबाद में 40% हमारे से, वो भी एक या दो एंटीबायोटिक बिजनेस के, जिसके कारण में आप डाल दो हमारे से निकलता है या फिर निकलता है एक एंटीबायोटिक या दो एंटीबायोटिक देख करके हमारे लोग के खड़े रहते हैं और क्या करें?
बिल्कुल ठीक है सर। एमआरएस is something which can threaten the life seriously, you know. Starting with here and going on to sepsis and patient dying because of a ENT infection. It's a hot topic. Vancomycin और लाइनक्लोमिड दो ही choices हैं आपके पास।
उसमें से एक को आप छुपा लीजिए, उसकी रिपोर्ट ही नहीं बनेगी, और एक तो चले जाएगी, नहीं तो वो दूसरी भी चली जाएगी, रिजर्व आपके पास कोई नहीं रहेगा। दिस इज कॉल्ड रिजर्व एंटीबायोटिक पॉलिसी व्हिच इज वेरी
वैंकोमाइसिन को जैसे हम यूज करते हैं ना, इट हैज बिकम जैसे रूटीन में ओपीडी ट्रीटमेंट चलती है ऐसे
सर मैं बताऊँ अपना एक्सपीरियंस। In 90s I went to Muscat, और वहाँ से पहला जो मुझे वो मिला कॉल फ्रॉम द पेशेंट, एंड आई वेंट दैट वार्ड, एमआरएस ऐसे गिरा हुआ है, कपड़े पहनो, चेंज करो, ऐसा मैंने कभी इंडिया में देखा ही नहीं था। तो पहला एमआरएस में देखा कितना ज़्यादा प्रिकॉशन है, ग्लव पहनो, मास्क पहनो, ये पहनो, वो पहनो। मैं हंसने लगे, मैंने हम तो ऐसे ही ट्रीट कर देते हैं हमारे
दूसरे को दे भी देते हैं।
दूसरा एग्जाम्पल
एक नाम है सर जिनसे हम भी डरते हैं, हमारे कल्चर में भी सूडोमोनास ओरिजिनल आ जाए तब हमारे थोड़ी घबराहट हो जाती है। अभी ये एमआरएस से और ये नए आने शुरू हुए ना, एक्सटेंडेड स्पेक्ट्रम ई कोलाई, क्लेप्सियला, जो सारे ये
कैसे जाएगा नहीं, कौन सा बैक्टीरिया आ गई, तो वो भी नहीं मरती किसी से।
एंटीबायोटिक की सबसे बड़ी प्रॉब्लम ये है सर, अभी यू विल बी सरप्राइज्ड, देयर इज वन इनोवेशन करंटली जस्ट गॉन ऑन। डॉक्टर दीक्षित, देयर इज नाउ वैंकोमाइसिन वर्जन 2। जैसे टेलीफोन के मोबाइल के वर्जन आता है ना, ऐसे एक वैंकोमाइसिन का वर्जन आया है, व्हिच इज वैंकोमाइसिन वर्जन 2। अभी सर ट्रायल चल रहे हैं उस पे, एंड अभी जो अगले रिजल्ट्स हैं वो ये शो करते हैं दैट दिस मे बी द सुपर एंटीबायोटिक इज लुकिंग फॉर। बट मैं आपको बता देता हूँ, कोई सुपर एंटीबायोटिक 3 महीने से ज़्यादा सुपर एंटीबायोटिक रह ही नहीं सकता। जो भी नया आएगा वो सुपर ही रहेगा, 3 महीने रहेगा, 4 महीने रहेगा, उसके बाद फिर हम उसको भर देंगे पेशेंट्स को, और थोड़े दिन बाद वो सुपर से ज़रा फिर नीचे आ जाएगा। तो दिस इज
Thank you very much for your wonderful presentation.
Thank you. Smaller number of people, they are quality people. They don't have the option to look here and there. So I was connecting with all of you. So numbers were small, but they were the good
This is
listeners.
a not a small group discussion.
And सबसे बड़ी खुशी की बात है कि राय सर कहीं आता है। I'm sure we will have some protocols in place now with our request, and things definitely under his guidance. His residents will also behave in a better way, maybe.
Thank you, sir.
I would have wished these chairs should have been full with the clinicians.
Yeah.
I did wish that they would have had
Dhanvantari, yeah, true. Uh, so I just so I just request our chairpersons to
Sorry, I don't want to offend anyone on this, but having some large numbers at the tea time and the lunch time, and when the deliberations are going on, which is the main priority area for any such event organized by the organizers. So this is our अभी शाम को कल्चर प्रोग्राम होगा, गैला डिनर होगा, जो लंच पे नहीं आए थे वो डिनर पे वो भी आएंगे. The numbers are going to be still higher.
thank you, sir. Thank you for such a wonderful session, sir. Now I just request our chairperson to felicitate Dr. Gupta.
This will be vice photo है. अरुण मैंने कैमरा इसलिए दिया. सब आ जाओ. ये फोटो चाहिए. Come everybody. Dixit, come. Monica, you can join. Please. Great. Pleasure.
Wonderful, sir. Wonderful.
And I just a second. And I also yeah, actually. Will do, sir. And I
स्विच ओवर बहुत जरूरी है कि आपने कब स्विच ओवर करना है. ऑलरेडी क्लीन इलेक्ट्रिक सर्जरी करी है तो एंटीबायोटिक आईवी तो देनी होती है.
Ma'am, just I also request Dr. Monica Gupta, our head and professor of physiology department, pharmacology department, sir, ESIC, to felicitate our chairpersons, please. Doc- okay, Dr. A.K. Rai, sir, please, Professor and Head ENT, please, sir, join us to felicitate. Ooh, sorry. So, Dr. C.D. Tripathi sir and H.S. Rehan sir, both. So please welcome. Thank you.
को पॉलिसी बना के दी और उसके बाद हमने बता दिया कि उसकी कॉपी की है हमने, फिर डॉक्टर वल्लभ को उसका चेयरमैन बनाया गया, हमने एक्नॉलेज किया कि उनकी कॉपी की है। तो ऐसे हमारा पहला डॉक्यूमेंट बना था गंगाराम के उस पर। और बहुत पहले 2006 में अच्छा वो हाँ हाँ अच्छा वो चीज़ें तो
ब्रॉड बेस्ड कमेटी बनी थी जिसमें भाई साहब जो आप टेलीविजन की बात कर रहे हैं, हमने सदन में आईसीयू में बनाया, अच्छा चल रहा था, काफी पेशेंट हो गए थे। एक बीच में एथिक्स कमेटी के चक्कर में एक समरी डिजाइन बनी थी 4 महीने बाद, वहाँ पर अनेस्थीसिया डिपार्टमेंट जो आईसीयू का था वो हमसे लड़ गए। अगर ये काम करेंगे स्पेशल हो गया।
Yeah, I'm there. I'm there. Hello.
Uh, I invite our speaker, Dr. Om Lakta Bhagat, who is going to present on title Stress Resilience, Evidence-Based Intervention and Lifestyle Modification. For this, our chairperson of this session is Dr. Preeti Jain. That is Dr. Preeti Jain. She is a professor of physiology at the Maulana Azad Medical College. As a board member of Delhi University of Studies, she has actively developed quality medical education and curriculum for more than 20 years. And as a member of Institutional Curriculum Committee of Phase 1, she played a crucial role in implementing the CBME curriculum in her institute. Dr. Preeti is involved in many research activities, especially in psychophysiology, cognition, and exercise physiology. She has published more than 50 articles in various national and international journals and presented paper at national and international conferences also. Ma'am, I would like to invite you on the stage, please. Please join us. And our another chairperson is Dr. Himani Aluwalia. She's virtually present with us. She is director and professor and head in the Department of Physiology and registrar at VMMC and Safdarjung Hospital. She has rich experience of 26 years in undergraduate and postgraduate teaching of physiology. She has immense contribution. She has given her immense contribution through her research work in area of neurophysiology, pulmonary function, medical education, and medical humanity. Ma'am, we are glad you are here with us online.
Thank you
And
so much. Thank you so
thank you, ma'am.
much.
Thank you. So I give the stage to our speaker, Dr. Omlata Bhagat.
Good afternoon, everybody. It's my pleasure to introduce Dr. Omlata Bhagat. She is an additional professor in the Department of Physiology at AIMS Jodhpur. She has an experience of more than 20 years. Her area of interest are cardiovascular physiology, especially cardiac autonomic responses to the wellness practices like exercise, respiratory training, yoga, and meditation. She is presently working in the Autonomic Functions Lab. Okay. So, Dr. Omlata Bhagat, it's a pleasure. Please start your talk.
Thank you for the kind introduction, ma'am. So, please, can you... So, when we talk of stress resilience, first thing which comes into our mind is the concept of stress, which is still unknown arena on a way or a confusional thing. If we put stress as a keyword, we came across more than 2.5, like 2.5 lakh publications, all having a different definition of stress. When we talk of stress in physical, in the terms of physics, it's a precise definition of stress as the force per unit area and strain as a deformation of a solid subjected to that force. Our concept, and this concept is very much similar when we talk of the stress on a on organism, and because this stress is or the force upon the living organism and its response. The the canon and has proposed this when he came with the idea of homeostasis, and he talked about the stresses and strain of homeostasis, and then it idea was further given a different dimension by Selye, and he has given the concept of generalized stress response. so oh my God. So this this concept of stress is there in yogic literature way back before Canon and all. And here the mental agitation is being taken as the cause of the disease. So that Adhi and Vyadhi are the terms which they use in the Indian ancient literature related to yoga. This changing concept is now, previously people were talking about the stimulus and the response. Then they came about and improve it with the stress and no stress. Now the present scenario in which they take it as a concept of stress, where the response is so the stressor is weak, so response may lead to the weakness of that response system, and then distress, where the strong challenge is being given and the person get a damage in turn. Whereas there is something called as eustress, it is a mild challenge to the system, and that helps in developing the resilient system, and that is a beneficial and this is a complex interaction between the autonomic nervous system, and autonomic network is involved in the stress response. The stress response are integrated at the levels of cerebral cortex, amygdala, hypothalamus, periaqueductal gray, pons, medulla, and via their descending projection affecting the several nuclei within these levels. And these selective nuclei within each level have specific connections that mediate different aspects of stress response via descending output to premotor and preganglionic neurons in the medulla and spinal cord. And these connections are very complex. So let's just try to see an hypothetical pattern of these stress responses. When a person is get a stressor in the initial time, so we can divide these people into the chronic response of the stressor. Those who are very vulnerable, they first have a normal within physiological response which get aggravated over the time, and then we have a resistant people who are actually in initial phase they respond within normal limit, and then they resist but the amplitude or the mod is just reduced. Whereas the resilient people, those start with the normal response, but a long-term effect is very much less, so they can modulate their own responses to stress in a long run. Resilience concept, we can say that the resilience to stress is characterized by an initial response to a stressful stimulus, but a relative recovery towards the baseline. So it is therefore both a process that occurs over the time and an outcome. It is important to differentiate between resilience from the resistance or from any other response pattern which is there, because there are different neural substrates are being involved. So as you can see that there are so much and so many patterns are, internetworks are important, and so what we can see that the autonomic nervous system and the HPA axis are interacting to have a stress response as the stimulus or the stressor is there, and which in turn gives you a cognitive change or a behavioral responses to that. And we can use the respiration control to modify all of these. So, and we all know that what is heart rate variability? Heart rate variability is a variation between sequences and consequences of heartbeat, And uh, this is what is happening. And there are studies which have shown that the heart rate variability is taken as a index for stress resilience, and lower the heart rate at the baseline can be taken as a better resilience in the situations which are there. So we all know that there is an interaction between the respiratory system and the cardiac system, and respiratory sinus arrhythmia is a fluctuation of the cardiac cycle interval which is synchronous with the respiration, and this relationship is being taken as an index for vagal tone and the parasympathetic nervous system. And this system is this relationship is temporal in nature, and it is not just in the cardiac, but it reflects in the systolic blood pressure changes. So there is HRV and BPV covariance is seen with respiratory modulation. And how we modulate the respiration, we can have these all the things which are resting, then we can change the volitional breathing rate, depth and resistance. We have developed a paced breathing module with the help of human voice based instructions, and with the help of this we can rate and can maintain the thing easily. What we did was actually this study we did was, what we did is we asked the person to breathe with the same frequency but paced, and we can see that the time domain analysis and frequency domain analysis have shown that the though it is a volitional activity which should have increased the sympathetic activation, but you can see that the HF power increases, so that means the parasympathetic is improved, as well as the SDNN, SD1 and SD2 ratio also showed the same thing. Also, when we analyzed the peak frequency as a function of the respiratory rate, in a spontaneous breathing, when a person is not conscious about the breathing, you cannot see the reflection of the frequency in the peak frequency, whereas when the person is doing a paced breathing, this frequency component is being reflected in the peak frequency of high frequency range. And therefore we can say that the conscious paced breathing resulted in the enhanced power of HF and reduced LF and HF ratio, which may be reflecting the mechanical effect of respiration and also indicating increase in parasympathetic dominance. Time domain parameters showed increase in overall autonomic tone during conscious paced breathing. And when we add we have gone a step ahead, and we have given the inspiratory resistance with the help of this respirate, and what we can see that a similar results, that the SDNN increased, the normalized low frequency decreased, and LFHF ratio also decreased. And so this data has given us the information that volitional breathing shift the cardiac autonomic control towards the parasympathetic at the same frequency of the autonomic, spontaneous breathing. And this magnitude of change is even more if you add a inspiratory resistance to the breathing. When we try to change the rate, we can see that the maximum RSA, that respiratory sinus arrhythmia, is the largest amplitude we can get at the rate of 6 breaths per minute. And also the balance also is the maximum at this thing. So respiratory sinus arrhythmia magnitude is highest at low breathing rate at 6 breath per minute, and people have used this frequency near about like 5 breath per minute as coherent breathing frequency, or the resonant breathing frequency is also being used where the maximum HRV is being. So they are saying that for individual people, coherent resonant breathing frequency may differ, but it is between the 4 to 6 breath per minute. So, and paced breathing frequency at higher frequency influences the sympathovagal balance with the gradual increase of 10 breaths per minute to 30 breaths per minute. This physiological intervention could have therapeutic implication in autonomic modulation. So, the question then is like whether this slow breathing intervention can modulate the response to stress. So, we have given the cold exposure and elicited the pain, and we see, so what we can see that though the pain threshold does not change after you give the slow deep breathing for 5 minutes, but to if you see that what is important is that the 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 tolerance increases. Now the person can tolerate for more time. So it's a significant change we can see in the pain tolerance. So therefore we can say that slow deep breathing, which is a controlled breathing with a low rate and high tidal volume, and virtually shakes up the regulating and regulated variable points within the normal limit, and it reduces the sympathetic activity by enhancing central inhibitory rhythms, thereby influencing the respiratory sinus arrhythmia and blood pressure oscillations. It also improves the efficiency of ventilation by increasing the alveolar and reducing the dead space ventilation as the result. So therefore, this can be emphasizes the possibility to integrate involuntary nervous system mechanism with higher cortical mechanism that are under voluntary control. So we can actually voluntarily change our response to stress if we train our system with a simple thing like breathe. Only thing we have to. And how is this happening? So it is happening because there are interactions which says that the slowly adapting receptors as well as the rapidly adapting receptors at the lung level, and thereby the center for periventricular nuclei, then central nuclei for amygdala, locus coeruleus, and these things, and then they affects the respiratory enhanced low rhythms in the brain, and thereby people have shown that the slow and hypothesized also that the slow breathing or the resonant breathing can be used as a bottom up intervention targeting the vagus nerve to increase resilience. And the locus coeruleus, amygdala and hippocampus are then mediates the effect of slow deep breathing on anxiety, attention and memory, thereby improving the stress resilience, because many a times these are the memory issues or the attention towards a stressful event and going back to that memory is eliciting more and more stress responses. So based on this thing, we can say that the pranayama is one thing which is age old intervention which we have with us, can be taken as a lifestyle modification for improving the stress resilience in the people. 80 to 90% of people usually are stress resilient, but we can actually improve that window where we can improve our homeostatic mechanisms, and we take as the elastic property of our system. So the take off message is that when we do a slow deep breathing through pranayama, Because when we talk of pranayama, we talk of breath holding. So usually, the classical concept of pranayama is with the breath holding. So it usually reduces the depth. It improves the depth and reduces the rate. So this, and while recording, you can see that during pranayama, this cyclical and the slow and deep breathing mechanical effect can be reflected in all the other parameters like ECG, blood pressure, oxyhemoglobin, that FNIR system, and this can be taken as that. Then what we are targeting is this thing, this area where we are targeting this area of homeostasis where the elastic changes are there. So we can increase this window with the help of just a simple exercise of slow and deep breathing. Any form of slow and deep breathing can have this effect, because we have an experience of even if the pranayama changes, a small difference is there, but overall difference is that same. So thank you. This is my team. With the help of them,
Any questions? Anyone?
Dr. Omlata, am I audible?
Yes, ma'am.
Okay. First of all, heartiest congratulations on a very nice presentation. You have picked up a very important and very relevant field of research in today's time when most of us are facing the problem of stress. So before I ask my question, as Dr. Preeti has also said, any questions from the audience?
I would also like to congratulate Dr. Omlata, because this was really a very nice talk, and this is a very in talk, especially considering the COVID factor, and we all know that mental health is also becoming an issue, and stress has actually been, a very, you could say it's a burning issue these days, and being locked down in our homes and with a simple exercise like pranayam, you say, right? It's a wonderful thing. If Dr. Himani would permit, I'll just ask her one or two questions, and then ma'am, you can
Yes,
take
ma'am,
over.
please, Dr. Preeti, yes.
Okay. Dr. Omlata, I would just want to ask, जो आपने ये exercise कराए है, was it for a certain duration, or is it an acute effect which you saw?
Ma'am, we have whatever I've presented is the acute effect.
Okay.
Yeah, we just one single. So I'm just trying to give you a glimpse that even a single episode of 5 minutes exercise practice of slow deep breathing in any form, whether it is just a volitional breathing or with the resistance, or in the form of pranayama, that anulom vilom pranayama which I have shown. So anything where you can take your breathing rate less and you're calmly doing a slow deep breathing can have effect, where though we are doing it consciously, yet we are actually challenging our vagal system and thereby improving our vagal tone. And people, the studies have shown that within the 6 weeks of practice of regular slow deep breathing can enhance the resting parasympathetic values also. So but that was not my data, so I have not presented.
And you, in one of your last slides, you showed the FNRIS pattern also,
yes,
in which you had shown the difference in the deoxyhemoglobin and the oxyhemoglobin. So that was also a part of your study.
Yes, ma'am.
Okay, so you simultaneously took that recording.
Yes,
that was a simultaneous recording which you took.
Yes,
okay, that was a wonderful thing, because recording it and seeing hemodynamic changes which are occurring in the brain simultaneously.
Yes, ma'am, this paper is under publication, so I have not presented all the data.
Okay, okay. So you must have done some cognitive test in that also.
No, ma'am.
You haven't done. Okay. It's a wonderful study. Yes, Dr. Himani, please.
Yes, Dr. Preeti, I think again I'd say that a very nice presentation and a very important one. I have one question to ask Dr. Omlata. Before you made these subjects do these breathing exercises, so in your screening, when you were screening for your subjects, what were the exclusion and the inclusion criterias? Number one, did you do any kind of personality assessment before you enroll the subjects in the study? And secondly, were they, I mean, what were the exclusion criterias, and was any kind of psychological or personality screening was done for these subjects?
Ma'am, we did the psychological general well-being index for all of them, and those who cross the normal life, those patients are only, sorry, those subjects or volunteers are only being taken. Those we excluded, those have a issue of anxiety, and so that way we have used the apparently healthy people with normal psychological well-being. So
Okay,
that is one thing.
perfect.
And
So
we
it means that
excluded all the people. We excluded all the people who have any scope of having autonomic baseline. So those with the low autonomic tone and those who have a normal psychological well-being are taken in the study.
thank you very much, and that's what I wanted a clarification on. Thank you so much. This was a very nice presentation.
Thank you, ma'am.
Very nice presentation. I would like to invite our next speaker, Dr. Rakesh Kumar Dikshit. Currently, he is a professor at Department of Pharmacology and Therapeutics, King George Medical University, Lucknow. He did his MD from GSVM Medical College, Kanpur University in 1997. He is a life member of Indian Pharmacological Society, British Pharmacological Society, National Academy of Medical Sciences India, Association of Physiologists and Pharmacologists of India, Indian Medical Association, and many more. He has been facilitated with prestigious fellowships like FIMER, Fellowship of International Medical Sciences Academy, Fellowship of Indian Society of Chronomedicine, Fellowship of Indian Academy of Biomedical Sciences. He's been awarded with the Best Teacher Award in Medical Faculty at KGMU Lucknow 2020, Appreciation Award from Honorable Vice Chancellor of KGMU Lucknow, and CL Malhotra Award for Best Paper at APPI 2010. Till now, he has published total of 166 research papers, out of which 129 are research papers and 37 are review, with total citations. We welcome Dr. Rakesh Kumar Dikshit for his talk.
Okay, not working. So, good afternoon, everyone. Good afternoon. हाँ, खाना खाने के बाद 2-3 लेक्चर के बाद यही होना है, तो कोई दिक्कत नहीं है, ये पता था. So, what I will do, I will change my talk. Thank you, madam. I am thankful to organizers for giving me a platform to share some views regarding the alternatives to the animal studies. Now, much has been talked, much has been discussed about whether the animal should be used or not. So that is my views I will share with some of the scientific data which I have collected through the literature. So now here you can see that even the animals, now they are fond of computers. They also don't like life. So we also have to adopt the things. So we are God's own creation. Nobody can match us. सपोज करो मेरे को कोई दवा चाहिए और मुझको उस दवा पे ट्रायल कराना है कि वो दवा काम करेगी नहीं करेगी, तो वो ट्रायल किस पे होना चाहिए? वंडरफुल, वंडरफुल, बहुत बढ़िया, मेरे ऊपर ही होना चाहिए. बट अनफॉर्चुनेटली ये पॉसिबल नहीं है. सो व्हाट विल डू, वी गो लिटिल बिट डाउन. तो और नीचे आएंगे तो हमारे रिलेटिव, और नीचे आएंगे तो फिर जनरल पॉपुलेशन, और नीचे आएंगे तो एनिमल आ जाएंगे. तो व्हाट हैपेंस व्हेन यू एक्चुअली वांट टू डू समथिंग, यू take two considerations. One is idealism, ideal. Ideal is the trial should be on me. That is ideal. But the second is practical. The practical is we have to adopt in between, that we can have appropriate thing which can be utilized on my body with other methods. So predictions are always, and predictions may be true, may be not. जब कहते हैं ना कि सबसे ज़्यादा कहा है कि साहब कि ह्यूमन में स्टडी मैच नहीं करती है एनिमल्स वाली, एनिमल्स के जो डेटा है वो रिप्लिकेट नहीं करते हैं हर बार एनिमल्स में. सो दैट इज़ ट्रू. दो भाइयों का बिहेवियर मैच नहीं करता है तो एनिमल की स्टडी ह्यूमन में 100% कैसे मैच कर जाएगी? तो दैट इज़ नॉट पॉसिबल. सो दैट, बट वी हैव टू गो विद दिस. क्लोजर इज़ द बेटर. सो दैट इज़ गुड. We think that animals are humans. No. We think that we are animals. No. We are in between. So neither the rat is 70 kg man, nor we are 70 kg mouse. Recall our UG's days, undergraduate days. अपने स्कूल के सबने बायो ली होगी, सबने बायो में एक एक्सपेरिमेंट किया होगा जब आपको सबसे ज़्यादा एक्साइटमेंट हुआ था. उतना एक्साइटमेंट हमारी समझ से मेडिकल कॉलेज आने में के बाद में नहीं हुआ था. जब आपने क्या किया था? फ्रॉक का डिसेक्शन किया था और बड़े उससे ओ फ्रॉक काट के आए, जैसे बहुत बड़ा ऑपरेशन कर दिया आप. ठीक है. नाउ दैट वाज एक्चुअली द बिगिनिंग ऑफ द एनिमल एक्सपेरिमेंटेशन इन आवर लाइफ. देन वी हैड दीज UG and PGs. Now because of the rules and regulation and the need, because what we can teach here in the real, they can be taught in other ways also. तो जब आपके पास अल्टरनेटिव मौजूद है तो आप लाइव को क्यों, जब आपका बच्चा पिक्चर में डांट, पिक्चर में मार जो पड़ रही है उससे देख के अगर ठीक हो सकता है तो उसको मारने की क्या जरूरत है? अगर आपने एक पिक्चर दिखा दिया बच्चे को और जिसमें पिटाई हो रही है और उससे उसने अडॉप्ट कर लिया, तो इट इज़ बेटर टू हैव विद द पिक्चर एंड ऑल अदर थिंग्स रादर देन विद द रियल. सो फीलिंग्स आर देयर, वी हैव फीलिंग्स, एनिमल्स आल्सो हैव. सो दैट इज हाउ. कुछ दिन बाद यही होएगा. सो एनिमल्स विल बी इनसाइड एंड एनिमल्स विल बी इनसाइड आउटसाइड डूइंग द एक्सपेरिमेंट ऑन द humans. And because of this, the last came कि साहब आप stop animal experiments. So हर चीज़ की हम लोग क्या करते हैं, हद कर देते हैं. फ्रॉक पढ़ाया जब फ्रॉक की स्पेलिंग नहीं आती थी उस समय फ्रॉक कटवा दिया. क्या फ़ायदा मिला? उसको ज़रूरत क्या थी? कितने फ्रॉक ख़त्म हो गए, अल्टीमेटली बैन लग गया. अगर वही फ्रॉक बचे रहते तो सारे फ्रॉक बचे होते और वो फ्रॉक अब पीजी में लड़का यूज कर रहा होता. तो पीजी मीन्स इंटरमीडिएट, हाई स्कूल से लेके पीजी तक का जो गैप था उस समय जो यूज किया गया, दैट वाज यूजलेस. और उस यूज की वजह से जो आज ज़रूरत है पीजी को, उसको ख़त्म किया गया. सो दैट वाज एक्चुअली मिस्टेक कि कब यूज करना है, कब नहीं यूज करना है. एंड नाउ द इरा केम दैट ओके, वी हैव टू सर्च फॉर द अल्टरनेटिव टू द एनिमल्स. So how the session has been planned, I have some history related to this, and I'll go with some formula. One formula is everybody knows, that is R formula. Second formula I have searched out, that is S formula. Third is ABCDEF, that I have devised by myself. So now I'll start with the history. If you go with the newspaper cuttings and other things, everywhere it is related to the animals. But if you think that animals use शुड बी 100% बैन, तो आज की डेट में शायद हम में से आधी पॉपुलेशन गायब हो चुकी होती. क्यों? बिकॉज कोविड वैक्सीन नहीं आती. कोविड वैक्सीन नहीं आती तो हमारी रेस जाती. तो किसने सबसे ज्यादा हेल्प किया? एनिमल्स ने. So it is very easy to say that 100% animal experiments should be banned, but it is not possible, and it is not advisable also. So animal experimentation in the PG teaching, training, how much it should be used, the number of authors, including the renowned Ravindra sir, he has also advised that, okay, we have to go with the caution, but not the 100% ban. Just think, if everything is banned, then it is not possible, it was not possible to have corona vaccine. So most of the time, we have to go with in between. And the third term I have devised, that is BAP. If the BAP is similar, the results are similar. So what is BAP? Biochemistry, anatomy and physiology. और BAP की शुरुआत होती है फर्स्ट ईयर से. फर्स्ट ईयर में जो फर्स्ट प्रोफेशनल के सब्जेक्ट हैं वो भी BAP हैं. दैट इज बायोकेमिस्ट्री, एनाटॉमी एंड फिजियोलॉजी. आप देखो तो अगर किसी का अगर ये सिमिलर है तो चांसेज आर देयर प्रेडिक्शन विल बी गुड. बट even the animals, they also have some similarity to the BAP. Maybe anatomically they may look very different, but biochemically the reactions are going very similar. So that is how they are utilized. And ultimately, so here the animals, they become the first choice. The history started with the Aristotle way back. Then renowned scientist Abu Joher, he was actually, he is known for the animal experiments, and the father of physiology, Claude Bernard. He has done, he did a number of experiments related to the medical knowledge, safety, pharmaceutical, cosmetics, chemicals, etc. So animals are used to improve everything, including the education and training. जो जितना हाय तौबा मचता है वो इस पे बचता है. अभी दिखाएंगे आपको, तो सबसे ज़्यादा मज़ेदार है कि इस पे मचा हुआ कि ये सब बंद कर देना चाहिए, बंद कर देना. कितना % आप सोचते हैं एनिमल इसकी वजह से किल होते हैं? बताओ. Sir has given 100% result, 100% correct answer. Only 1%. Only 1%. So that is the beauty. हमारे यहाँ जो 1% है उस पे हाय तौबा है. 99% जो हो रहा है उस पर कुछ नहीं. सो दैट इज हाउ. एंड 1% एजुकेशन पे सिर्फ खर्च होते हैं एनिमल्स. बट अनफॉर्चुनेटली उसको इतना ज़्यादा आय तौबा बना दिया कि सब जगह बंद कर दो, सब जगह बंद कर दो. एंड आउट ऑफ दिस, इफ यू सी हियर, वी आर इन द मिडिल. फिजियोलॉजी एंड फार्माकोलॉजी इन द मिडिल फॉर यूजिंग द एनिमल्स फॉर द एक्सपेरिमेंट एंड रिसर्च पर्पसेस. सो what are the animals commonly used? Rats, mice, guinea pig. गिनी पिग सब बताते हैं क्योंकि गिनी पिग का सब उसमें पेपर में आता है. ह्यूमंस आर नॉट गिनी पिग, बट अनफॉर्चुनेटली गिनी पिग आर वेरी रेयर टू बी यूज्ड. ठीक है. हाँ, गिनी पिग नहीं होता है सबसे कॉमनली. सबसे कॉमनली कौन सा होता है? माइस, रैट, देन wonderful. They are substitute. Now they will be the second part of the lecture. So that is actually MRF tire. सुना है ना आपने? Now, so mice, rat, fishes, and the birds. They are four. They are actually most. They make the bulk of the animal experimentation. नंबर ऑफ व्यूज आर देयर. सम आर इन द प्रो. सर हमारी तरह का कहेगा कि साहब होना चाहिए, किसी दूसरी का तरह का होगा कि नहीं होना चाहिए. अल्टीमेटली हमारा भी कहना गलत है, उनका भी कहना गलत है, बीच का रास्ता होना चाहिए. सो सम सेज दैट ह्यूमन राइट्स ओवरराइड द एनिमल राइट बिकॉज वी आर इवोल्यूशनरी एट द टॉप. सो वी कैन डैमेज एवरीथिंग. तो हम सब कुछ खत्म कर सकते हैं, अपने को भी खत्म कर सकते हैं, और वही हो रहा है जो गलत है. बट आप अगर हायरकी में ऊपर हैं तो यू कैन नॉट ओवर रूल अदर्स. Diseases can only be understood by managing on the livings. That is true. an animal experiment that can benefit the health of the animals also. That is very right. That is very right. अब अगर हम कोई एक्सपेरिमेंट करते हैं ऑन एनिमल्स, तो पर्पज़ ये होता है कि ह्यूमन तो बेनिफिट हो, साथ में एनिमल भी बेनिफिट हो. जितनी एंटी माइक्रोबियल्स हैं, दे आर फॉर ह्यूमंस ओनली, नो, मोस्ट ऑफ देम दे आर फॉर द एनिमल्स यूज आल्सो. कहाँ से आती? अगर वो न बनाई गई होती तो कहाँ से आती? तो अल्टीमेटली the humans are getting benefit, animals are also, and nothing can substitute the living. So this is the favor, and that is true. Life is a very complex, living thing, living tissue, living organ is a very complex, and that cannot be matched with any sort of chip or any sort of computer programming. And if you remove the animal experimentation, there will be the negative impact. That is true. Anti-animal experiments persons, they are saying that, okay, animals also have a right to live with the dignity. That is true. Animal reaction to the drug may be different. That is true, but acceptable. And that I have already told, because nothing can match the human body. So that, but the practical way is to have utilize something which can actually give some clue for the utilization of the human body. So need the alternatives are ethical and other. So we have to go with the rational approach. And now coming to the formula, that is 3R. We have to reduce, refine, and replace. So how to reduce, how to refine, and how to replace. Reduction is very easy. Reduction is very easy. How? If your plan of the research work is very strong, statistically well designed, number of the animals will be reduced in one study. If you have done a good study in a good manner, good laboratory practices and all these things, your data will be concrete and acceptable by everyone. Now, if you are doing this study here, I am doing one similar study at the KGMU. Now, that is duplication. Now, this duplication can be reduced if you do here with wholehearted and with all the scientific issues. Now, your data will be allowed to take for my purpose. My data can be given to the your purpose. Now that will reduce the animal use, and that is the actually purpose of OECD. जो पूरी दुनिया में जो OECD प्रोग्राम या OECD जो बना है, treaty है, now that is you do the things in a scientific way, in such a way that your data can be shared. So that is the formula of reduction, fewer animals, and the sharing the data. Strong hypothesis, statistical conclusion, and sharing of the accepting data. Replacement, you go with the lower animals rather than the higher animals, go, and that replacement is already has been done. So you will not find many places the experiment over the monkeys, the higher animals, dogs, rats, dogs, cats, etc. So they have been replaced with the in vitro, then computerized bioinformatics techniques, lab on the chip, then study, the instructions can be given, or the teaching can be rather than live, they can be through the computer assisted learning, utilizing the living from the lower strata, human skins, human blood can be utilized for this purpose, and the last one is why not human? So human itself, they can be used. Refinement is by using the technique which minimizes the potential pain and suffering. That is by better housing, reduction of the noise, better place, the choosing the experiment which has actually the less time. And you have to increase the R's. So reduce, replace, refine, rehabilitate. The second, the fourth R as acceptable, rehabilitate. Then came the reuse, then revise, then register. जब आप register करते हो तो use कम हो जाता है अपने आप. If you start registering antibiotics, the use of the antibiotic will be reduced. If you हम लोग जब यूजी किए थे पीजी किए थे there were no register maintained in the animal house or other things, so you just take animal and use. Now here if you make the registration very stringent, then the use will be reduced. And report any bad happens with the animal, anything happens with the animals, that should be reported. So these are increasing. The 3 R to the, that is reduction, refinement and replacement. Now the other R are rehabilitate, reuse, revise, register and report. Now the S principle is, that is good science. You have done experiment, you have done research with bad science on so many animals, that is useless. Less number of animals with concrete data, concrete statistic, a good methodology, that is good science. So one S is good science. The second is a good sense. That is your data can be translated into the human models. Good sensibilities, because you have to have sense that animals also have pain, and because of that you have to plan method which actually gives the reduction in the and the sharing of the data. So these are the S principle. So science, sense, sensibility and share of the data. Sharing of the data is very crucial, because if 10 institutes are doing same study, useless. One institute does the study with the sharing of the data to the all 10. That will reduce the use of the animals. So alternatives can be reduction, replacement, refinement, in vitro, in silico and all these. So some of the things you must have heard. कुछ आपने सुना होगा, कुछ नहीं सुना होगा. आर्गनॉइड का नाम सुना है? आर्गनॉइड. आर्गन का नाम सुना होगा, आर्गनॉइड का नाम नहीं सुना होगा, है? ठीक है. सो चिप का नाम सुना होगा, ठीक है. लैब इन चिप का नाम नहीं सुना होगा, ठीक है. सो ऑल दीज थिंग्स दे आर एक्चुअली कमिंग. तो ह्यूमन सेल या एनिमल सेल को मल्टीप्लाई करा के उस तरह का शेप देना, बिकॉज सिंगल सेल विल गिव द रिजल्ट विच विल बी लेस यूज देन मल्टीपल सेल्स टिश्यू. The result at the tissue will be of less use than the organ. So what they have done, they started, सबने सुना है stem cells and all this. So cells are cultured, and the experiments are done on the cell culture. Now the cell culture experiments, they will give results, but they are of low quality. So what they did, cells converted into the tissue, converted into the organ, and those conversions, the name has given organoids. So that is how the term came. So it's all about in vitro, in vivo, in situ, in silico, and in chemico. And that is how the replacement is going on, and hopefully the results will be soon good. Cell culture and tissue engineering, that was the first, but the results are of low quality. So what they did, they made a system which is actually mimicking to the organ, and they called as organoid. Three-dimensional picture, three-dimensional way, and similar to and which work actually similar to the organ. Then कैंसर सेल्स, कैंसर में बहुत ज़्यादा इम्पॉर्टेंस है एनिमल रिसर्च की, एंड कैंसर सेल्स कैन बी कन्वर्टेड इनटू द ट्यूमरॉइड, एंड द ड्रग इफेक्ट एंड द अदर थिंग्स दे कैन बी स्टडीज वेरी वेल, एंड विच एक्चुअली गिव द सिमिलर good results which can be translated to the humans. Then use of the invertebrates, which you have till, जो लड़की थी वहाँ बैठी थी, क्या नाम, कहाँ चली गई, ये बता रही थी ना, ड्रोसोफिला. हाँ, तो इन्वर्टिब्रेट्स का यूज. जेब्रा फिश उसने बताया था, उसको थैंक यू बोल देना, ठीक है. कह देना जब तुमने बताया तो सर ने लिख लिया था, ठीक. So that is how we can replace the bigger animal by the smaller one. high throughput screening, and the chips are now coming up. So what is difference between the organoid and the chips? The chips are actually just like a SIM card, and they are actually having the tunnels and all these. So here the fluid travels and does the similar reactions which the particular organ is doing. So here actually you put a drop of blood here. This will go through the tunnel and all that, and this will produce certain effects, certain reactions, which can be actually assessed through the computer. And that is actually the era which will come in near future. That is the lab on the chips. Lab on the chips. Yes, 3D chip on the for your experiments, which actually will be mimicking to the human values. So there are certain initiatives globally, that is Shushrut 1 and ecotographs. They are actually they are initiatives which are actually replacing all these animals with the chips and other methods. This is a platform, Narcopia, that actually is for the teaching purpose. So you just open this and you will have thousands of models which can be utilized for the teaching purpose. Our ex-pharma is one of the part of this Narcopia. Ex-pharma, pharmaco, they can be utilized. Excology. So all these, they are softwares, and they can be utilized for the teaching purpose. For UG teaching, absolute no need of animal experiment. Everybody is convinced. Everybody is convinced. Bas khatam. So research is also supporting that they can be, it can be used. Now the last one is the final. Final is that limited priority stage for the educational purposes, and the most important thing is that complete replacement cannot be done. That is the big no. Take home message is utilize R, utilize S, and ultimately do the experiment in the human way. Thank you very much. Thank you. Any comment, questions? तुम बेटा चले गए थे, तुम्हारा मैंने बता दिया वो जो तुमने बताया था ना कि वो ड्रासोफेला वगैरह सब बता दिए. ठीक है, थैंक यू. हाँ ठीक है. हाँ हाँ बताओ. हम तो टीचर हैं, हम तो इसे पूछेंगे. हम बताएंगे थोड़ी ना कुछ भी.
Any questions from any audience? Hello, Dr. Rakesh.
हाँ हेलो.
आप इससे पहले कोई प्रश्न पूछे हैं तो मैं आपको बहुत बधाई देती हूँ कि आपने एक बहुत ही ज्वलंत और विवादास्पद विषय के ऊपर टॉक दी है. और it's a very controversial and a very burning topic, to whether to continue or discontinue the use of animals, especially in the postgraduate education. And the alternatives which are there, I mean, you have enlightened us with so many new things which have come up. So आपकी presentation बहुत सारी सूचना हमें मिली, बहुत सारी information मिली.
Thank you.
तो अब मैं श्रोताओं से कहती हूँ, audience, if they have anything to ask, the forum is open for discussion.
Dr. Rakesh, I would also like to congratulate you. आपका बहुत अच्छा टॉक था and बहुत informative.
मैं उधर देख रहा था एकदम से सब पका के. आपकी बोलने की स्टाइल एकदम मैच कर गई ना. That is actually अभी हम बोल रहे थे ना कि मैच suddenly.
सर आपको जान के खुशी होगी कि मैंने भी MD जो है GSVM मेडिकल कॉलेज से ही करी.
सच्ची में? अरे इसीलिए तो इतना बदमाश लग रही हो आप.
I take it as a compliment.
Good. Para?
I am from Para J1.
Okay. Now you are all surprised. Huh? What is this para? So in our GSVM we have a system of para. So para will tell you which year she is. ओके, दैट इज सीक्रेट है, तुमको भी नहीं पता किस ईयर की मैडम बूढ़ी लग रही है लेकिन पता नहीं ना, ठीक है सर बहुत बूढ़े हैं पता नहीं ओके बाय बाय एनीथिंग थैंक यू ये
Thank you,
मेरे
Dr.
को
Rakesh.
इसलिए थैंक यू
Thank you, sir. Thank you, ma'am. Now I just request uh, Dr. Monica, ma'am, and our chairperson to felicitate our speakers. First, Dr. Omlata Bhagat, ma'am. Ma'am, please. Now we can congratulate sir, uh, Dr. Rakesh Kumar Dikshit, sir. Now I request Dr. Monica Gupta, head and professor of ESI, to felicitate our chairperson. Both chairperson are here. One is virtual and one is offline. So. Thank you, Dr. Himani, for presenting here, virtually presenting here, and gracing our occasion. Thank you, ma'am.
And I must thank the organizers for giving us the opportunity to chair such a nice uh, talks. And all the best for the next 2 days also to the organizers. And I really wish that this conference is a thundering success. The first day has been very, very fruitful, and I wish the same for the remaining part of the conference. Thank you so
Thank you
much.
very much.
Thank you, Dr. Preeti.
Ma'am will see this. Ma'am को दिखेगा. Up to here only ना, stage ही तो दिखेगा. Symposium. Pointing at that.
I think we can log out now.
Yes, yes, ma'am. You can log out, ma'am.
Thank you so much. Thank you
Thank you,
all.
ma'am.
Thank you all.
Our next session is Symposium 4, which is on title Vestibular Stimulation as Physiological Intervention. For this, our chairperson is Dr. A. Good afternoon, sir, again, and now we are starting our next session, that is Symposium 4 on vestibular stimulation, physiological intervention, whose chairperson is Dr. A.K. Rai. Dr. A.K. Rai, a cochlear implant surgeon, joined ESI-MC in August 2020, and since then he is heading the Department of ENT. He has served various reputed organizations for 12 years. Dr. Rai was head of ENT department at Safdarjung Hospital. Along with that, he was also given the charge of medical superintendent of Safdarjung Hospital for 2.5 years. He was additional medical superintendent at LHMC and Dr. RML Hospital, New Delhi for 3 years. He was also head of department ENT at Dr. RML Hospital, additional DGHS at RML Hospital. He has published 6 original articles in different journals. Uh, Thank you, sir, for gracing our occasion. Is our Dr. Murnal Pathak online? We don't have. Okay. So, sir, I would like to request you to introduce our speakers.
Good evening. So we are going to start this session, and the first speaker will be Dr. Joseph Mukadan. He is a founder and research director of the Little Flower Institute of Medical Sciences. He is a professor and head of the doctoral department of physiology, and he has vast 35 years of research experience. His major scientific field of interest is neurophysiology. The other areas of research are electrophysiology of the vision, nutrition, and visual systems, developmental physiology, neurophysiology. He is also a recipient of Dr. Subbarao Memorial National Award 1994. So I invite him for his talk on this subject. Dr. Joseph.
Dr. Joseph Mukadan, sir. GK Mukadan. Sir, please unmute your mic.
Hello. Hello, we are ready. Kindly on the screen share. We will present it on screen sharing. Kindly open it. Screen sharing we got.
Yes, sir. Yes, sir. We are allowing, sir. Yes. Now you can share, sir.
Ah, very good.
Hello, sir. Still it is not able to share the screen. Hello, sir.
Yes. We allowed you. Just start sharing your screen. Just try to start.
It is showing that the host is disabled the attendees screen sharing.
Just give us a second. We are trying to fix the glitch.
Okay, sir. Okay, sir.
Sir, please on your video mode, na? Dr. JK, sir.
Yes. Yes, sir.
Disable. Hello.
Video.
Hello.
Hello, sir. Hello, sir. Am I audible?
Did for sharing your screen.
Yeah. Yes, sir. Yes, sir. It is clear now. But we cannot share the screen. It is not able to share it. The
From
host
our
is
side,
disabled
it's
screen sharing.
no. You can log in again if it is possible, right? Or refresh it.
बेटा ठीक है कंप्यूटर क्लास में
Hello, sir.
Yeah, hello, ma'am. Now you can present, ma'am.
Hello, sir.
Hello, ma'am. Please
Hello.
start sharing the screen, or we can request next speaker to start their
Just
slides.
1 minute, sir.
Okay.
Hello, sir. Can you please let in Dr. J.K. Mukherjee to the meeting? Okay, sir. It is connecting.
Dr. Devi.
Hello, sir. Yes, sir. Yes, the screen sharing is still disabled. It is not enabled, sir. The host disabled that screen sharing.
Actually, from our side, we had given the permission for sharing the screen. There is no glitches from our side. In between, if another speaker, Dr. Remya Paul or Dr. Joseph Mukadan, can share, whoever want to share the first.
Here, still we cannot share the screen still. I'll make arrangements there. Disable share. We are, it is again coming disabled share. Please enable share. Enable.
हाँ. ये किसका स्क्रीन आता है जेके मुकद्दम का
Disable. Again came disable.
Dr. JK, your screen is showing that that is enabled.
Yeah.
You can share the screen. There is no issue from that side.
Enabled ആണെന്ന് പറയാം.
No, but still it is showing that the host is disabled the attendee screen sharing, sir.
You just
Can you
start
please
sharing
make
the screen.
Dr. Jacob
Your
as but it is no, we are not able to share the screen, sir. The host is disabled the attendees screen sharing. It is showing like that. So make Dr. J.K. Mukherjee as a co-host.
അത് പറയണ്ട എന്നോട് പറയാൻ ഷെയർ
ഇവിടെ എഴുതി കാണിച്ചു പോസ്റ്റ് ഡിസേബിൾഡ് അറ്റൻഡീവ് സ്ക്രീൻ ഷെയറിംഗ് നമുക്കൊന്നും ചെയ്യാൻ പറ്റില്ല സെറ്റ് ചെയ്യും Hello, sir. Can you please make Dr. J.K. Mukherjee as a co-host? ഇനി ഷെയർ ചെയ്യാൻ പറ്റും
പറഞ്ഞാൽ മതി ഞാൻ എന്നോട് പറയാൻ പാടില്ല അവർക്ക് വളരെ അല്ല അത് ഇവിടെ വരികയല്ലേ
Hello, sir. Hello, sir. Hello, can you please enable the screen sharing now? From this account, in this account, Dr. Remya. Sir, still the screen sharing is not enabled. Hello, sir. Still it is not able to share the screen, sir. It is not coming, sir. അവരെന്തോ പറയുന്നുണ്ടോ ഒന്നും നമുക്ക് കേൾക്കാൻ പറ്റുന്നില്ലല്ലോ. Hello.
भाई मुझे भी दे दे, भाई मुझे भी दे दे। अब हेलो डॉक्टर रिम्या, रिम्या का माइक ही नहीं कनेक्ट, और डॉक्टर देवी, डॉक्टर देवी, डॉक्टर देवी,
Connected. I don't know why we cannot share the screen.
ma'am, she is logging again and again from different devices. So when we are giving
Yeah,
permission,
we are logging from different accounts, but we are not able to share the screen, sir.
do one thing, धन्वंतरी का login दे दो उन्हें, उनको शेयर कर दो ना
Now I think it is coming.
Okay, share हो गया. Yeah, it's coming now. It's
Yeah,
coming.
sir. Yes, sir. Thank you so much.
So, Doctor, please start, please.
Everybody. I am Dr. Mukardan from Little Flower Medical Research Center, Tangamali. In our lab, at Tangamali, we are conducting a very innovative research program, namely control as a physiological intervention to prevent or control a lot of physiological difficulties in mind. See, in this symposium, we are presenting three major topics. The first topic is impact of rotatory visual stimulation, memory boosting, and life. See, we have prepared a rotatory visual stimulation apparatus in our laboratory, and we have conducted an extensive work with that instrument. And notice that by using a rotatory apparatus, we can enhance learning and memory, reduce stress, and this can be proved by biochemical, physiological, and anatomical. Anatomically, it is proved that learning and memory is enhanced after muscular stimulation. So the Dr. Roy really will present it in detail. The next topic is another important topic, therapeutic effect of vestibular stimulation to control stress and free radical generation. That was very important. She has used a linear vestibular apparatus prepared in our laboratory, and she used an extensive work, and she showed that by using this deluxe stimulation, we can reduce stress and thereby control the sugar, high cholesterol, and many other things. And she has also proved it by anatomical, physiological, and biochemical methods. That was an excellent one. That she will present soon. The next topic is again another very important one, vestibular stimulation, a physiological intervention in. That's very important one. Stimulated by this animal experiments, we have also started this implemented. Patients and diabetic patients given vestibular stimulation, they used a simple swing model. And observed that by using this sim for 3 months, we have reduced sugar in pre-diabetic age and diabetic age, and reduced stress and reduce free radical generation, etc., etc. It's a wonderful work. We want to continue this work in a laboratory with the modern equipment. So far, we were using only a zinc attended by IIT Bombay. So this is all as an introduction. Now I invite Devi MP to introduce herself and give a talk on impact of rotative vestibular stimulation in memory boosting.
Thank you, sir, for inviting me to this symposium. Good afternoon, all. NP going to present the impact of rotatory vestibular stimulation in memory boosting in rats. Learning a behavioral task or something complicated with excess physical activity causing the subjects to shift away from homeostasis, which may result in the consumption of more energy, leads to physiological stress, as well as it in turn leads to the production of free radicals, which will lead to oxidative stress, and it can be harmful for proteins or DNA involved in dendritic growth, and it will get reflected in learning and memory performance also. Enriched environments and soothing physical activity, learning and memory. Here are some examples for environmental enrichments, like physical enrichments, like exercises and physical activities, jumping, swimming, swinging, etc. When it comes to nutritional enrichments, various plant resources and rasinas are there, and social enrichments, peer groups and social activities. Novel objects and accessories are visual, auditory and olfactory, colorful toys, tunnels and ladders, hanging objects, etc. And the significance of vestibular stimulation, self-soothing and focusing attention. When an individual is agitated and hyper aroused, sensory inhibition can be cast off to diminish arousal. Linear movement activities like forward, backward, rocking and swinging are calming, and such calming activity serves to inhibit the reticular activating system via the vestibular system. Some other examples such as cradles, vibrating mat, or a waterbed mattress helps to further soothe the over-aroused individual, especially children. Implementation of vestibular stimulation also helps a person who cannot concentrate on a tiresome project via a movement break every 30 to 45 minutes. For example, the person take a walk or do something, some other short movement break, and then return to the project. It is absolutely helpful if exercise can be introduced in the routine to regulate mood and attention. How vestibular system linked with the hippocampus. Vestibular signals reach the hippocampus through some major anatomical pathways. Vestibular stimulation can be considered as the input that our body receives the immediate movement. Vestibular stimulation can be of mild type of vestibular stimulation like nodding the head, climbing stairs, etc. And intense type of vestibular stimulation, for example, skydiving, roller coaster, and giant, etc. Rotate stairs predominantly active the semicircular canals of the inner ear, helps in the retention of memory via stimulating the hippocampus. Here you can see a schematic. The short movement and project. Absolutely help. Exercise can be introduced in routine to regulate mood and attention. Vestibular system linked with the vestibular stimulation can be read as the input that the body receives when we experience movement activity. And vestibular stimulation two types. While the type of vestibular stimulation like moderated time plus for example predominantly while the camp. Here you can see a schematic representation of vestibular stimulation and how vestibular stimulation is involved in cognition. Here we can see that vestibular stimulation hinder the stress axis, that is the hypothalamo-pituitary-adrenocortical axis as well as the adrenomedullary axis. While inhibiting the stress axis, the release of glucocorticoids and cortisol, those are stress hormones, and by reducing the amount or the quantity of stress cognition. And in another way, the vestibular stimulation also fires the hippocampal neuronal cells like cells as well as head direction cells. It also improves cognition. This is the anatomical pathways through which the vestibular signals reach the hippocampus. That is the stimuli goes to the vestibular stimulation. It may reach the pedunculopontine nucleus, and from there to the supramammillary nucleus, from there to the medial septum, then it reaches the hippocampus. And in another way, also the vestibular stimulation reaches the hippocampus. So these are some anatomical pathways through which the vestibular signals reach the hippocampus, and it in turn activates the hippocampus. And the hippocampus can be considered as the seat of learning and memory. And in our study, we have used the animals like male Wistar albino rats of 30 days old, weighing about 120 gram weight, and the rotatory vestibular apparatus. A new instrument stimulation. This instrument was designed out of fiber frame as a basement with 3 plastic cages attached on it to place the rats. The cages were about 15 centimeters length and 10 centimeters width. Only one animal can occupy comfortably in one cage without any entrapment stress. The device works on electricity, and the movement provided by this device gives vestibular stimulation in rotation mode. The speed of rotation was 50 revolutions per minute in clockwise direction, were fixed by trial and error method with 25 RPM and 75 revolutions per minute. This is a schematic diagram, schematic picture representation of vestibular stimulating apparatus that we have designed in our own laboratory. When it comes to the experimental design, the rats were randomly divided into different groups comprising of 18 rats, like group A, group B, and group C. In that, the group A is a control group. Neither vestibular stimulation nor the drug was administered to this particular group, and group B is a standard drug physostigmine treated group. So the
Sorry
rats
to
of
interrupt
group
here,
B
ma'am.
were
Please make
administered
it
with the
fast.
standard drug physostigmine 0.3 mg per kg intraperitoneally. And when it comes to group C, that is the rotatory vestibular stimulated group RVS, here the physostigmine is the standard drug that we have used in our experiment, and rotatory vestibular stimulation were administered to group B and C respectively for 30 days before the beginning of the behavioral task, and also 15 minutes prior to the start of acquisition phase as well as each retention test. Behavioral analysis and administration of isostigmine and rotatory vestibular stimulation.
Ma'am,
After
last
30
5 minutes,
days
ma'am,
of
please.
vestibular stimulation,
Because
the
of shortage
rats
of
were
time, you have
subjected
to
for
complete
behavioral
it fast.
studies in radial armies. The behavioral experiments were carried out in 3 phases, like orientation phase or training session, learning performance test or acquisition test, and memory performance test or retention test. The rats were semi-starved for 48 hours. Before the start of behavioral experiments, during the 3 days of orientation, the semi-starved rats were allowed to familiarize themselves with the radial arm maze. After
Dr.
the
Ramya,
orientation phase, the behavioral task was performed, where all the 8 arms of the maze were baited with food pellets, and then the rats were placed in the center of the maze and allowed to freely explore the maze. The rats were
Dr. Ramya,
required or trained to
just a
take the food
request to
pellet
make it
from each
fast.
arm without making a re-entry into the already visited arm. The training or trial was terminated when the animal learned to take the food reward from all the 8 arms or after 10 minutes if all the 8 arms were not visited. 6 trials per day was given in an inter-trial interval of 1 hour. To avoid olfactory cues, the maze was wiped with 70% of alcohol prior to each session. After acquisition phase, all the trained rats were kept for consolidation of the learned task for 10 days and the retention test was carried out until the rats attaining the learning criteria. For the assessment of learning and memory, the number of trials taken for attaining the task were recorded. For analyzing the long-term potentiation, the retention test was repeated for 7 times with 10 days of gap in between each test.
Dr.
This
Ramya,
is
are you
a
here?
schematic representation of 8-arm radial arm maze.
Hello?
The control rats or group
Hello?
A were undergone the same procedure of behavioral task without providing
Hello,
any drug
hello.
or vestibular
Check one.
stimulation. The rats of group B were administered with the drug physostigmine 0.3 mg per kg orally for 30 days without
Hello.
any vestibular stimulation and kept as the standard drug group.
Hello? Dr. Ramya?
When it comes to the neuromorphological
Hello, Dr.
analysis,
Ramya?
after the behavioral studies, neuromorphological analysis were carried out. The
Hello.
brain was shelled out and the hippocampus dissected out for processing with rapid Golgi staining method. After staining, the hippocampal sections were taken at
Hello? Dr. Ramya?
170 μm thickness using rotary microtome and camera lucida tracings of the hippocampal pyramidal neurons were done. Dendritic branching points and intersections were counted by Scholl analysis method. When it comes to the estimation of acetylcholinesterase activity, it was done by using UV spectrophotometer by Ellman et al. Method. Immediately after last retention test, the rats were sacrificed and the hippocampus was dissected out in an ice called 0.1 molar phosphate buffer saline. The hippocampus was homogenized in ice called 0.1 molar phosphate buffer saline using Teflon homogenizer and the homogenate were centrifuged at 5000 rpm for 10 minutes at 40 degrees Celsius. The supernatant were mixed with the 2.1 buffer and 1 milliliters of DTNP. After
Dr.
that,
Ramya,
1 milliliters of acetylcholine iodide added and the absorbance was measured every 1 minute for 10 minutes at 412 nanometer using spectrophotometer. Statistical analysis. The statistics were done using GraphPad Prism followed by Tucky's multiple
Dr.
comparison
Ramya,
post-hoc test is done in
excuse
the
me.
study. When it comes to the result, for the behavioral analysis, we can see that the effect of rotatory vestibular stimulation rats using Lami's task. The acquisition and the retention of the 3 groups were statistically analyzed using one-way ANOVA followed by Tucky's multiple comparison test. The acquisition test. The mean number of trials for acquisition in Group B and Group C shows a significant reduction when compared with Group A. But there is no significant difference between Group B and Group C, which indicates that rotatory vestibular stimulation and physostigmine are equally good at enhancing learning capacity. This is a retention test from the day 10th to day 70 after acquisition. So the same trend is repeating here also. That is group B and group C shows significant of 8 for retention when compared with group A. This is a graphical representation for the behavioral analysis retention. From the analysis, it is observed that the treated groups, group B and C, shows significant decrease in the number of trials taken for both acquisition and retention when compared. When it comes to the neuromorphological analysis, the dendritic branching points also shows long were seen. Was C shows significant decrease in the number of trials taken for both acquisition and retention when compared with the control group. But no significant difference was observed between group B and group C. In retention from the 50th day of trials within each treated groups. This indicates that rotatory vestibular stimulation and physostigmine are equally responsible for long-term. In group B and group C when compared with the control group. And there is a significant increase in the dendritic branching point. Reduction in the number of trials shows significant decrease in the number of trials taken for retention when compared with group A. This is a graphical representation for the behavioral analysis retention. From the analysis, it is observed that the treated groups, group B and C, shows significant decrease in the number of trials taken for both acquisition and retention when compared with the control group. But no significant difference was observed between group B and group C. In retention from the 50th day of retention onwards, a considerable reduction in the number of trials were seen within each treated groups. This indicates that rotatory vestibular stimulation and physostigmine are equally responsible for long-term potentiation. When it comes to the neuromorphological analysis, the dendritic branching points also shows a significant increase in group B and group C when compared with the control group. And there is a significant increase in the dendritic branching points in group C when compared with group B. This is a results for dendritic branching points. The same trend is repeating here also. That is group B and group C shows significant increase in the number of branching points when compared with group A, and there is a significant increase in group C when compared with the group B. We can see the dendritic branching points in group C has increased significantly when compared with the group B. From the analysis, it is very clear that the dendritic branching points are significantly increased in treated groups when compared with the control groups. This is a graphical representation for the analysis of dendritic branching points. When it comes to the dendritic intersection also, the same trend is repeating. That is group B shows a group B as well as group C shows significant increase in dendritic intersection when compared with the control group. This is a graphical representation for dendritic intersection for the analysis of dendritic intersections. This is a pictorial representation, photomicrograph and camera lucida tracings of the hippocampal pyramidal neurons. Here also it is very clear that group B as well as group C shows increased dendritic arborizations when compared with the control group. When it comes to the biochemical analysis, the rate of acetylcholinesterase of group B and group C is significantly decreased when compared with the group A, that is a control group. And there is no significant difference between group B and group C. From the result, it is clear that the rate of acetylcholinesterase activity is reduced in treated groups of rats, and this in turn results in an improved learning and memory. This is a graphical representation for the estimation of acetylcholinesterase activity. It is decreased in group B and group C when compared with the control group. When it comes to the conclusion, learning and memory can be enhanced by rotatory vestibular stimulation via increased dendritic arborization and decreased acetylcholinesterase activity. The rotatory vestibular stimulation can be recommended as a safe and unpretentious way of improving learning and memory power. And further studies have to be done to find out the BDNF level in vestibular stimulated rats. These are some references. Thank you.
Thank you, Dr. Devi, for your excellent presentation. Now, session is open for a discussion. Anybody has got any questions, please ask questions.
Hello? 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 Hello, sir, are you still online?
I am online.
Okay, so the chairperson, Dr. A.K. Rai, would like to have a conversation.
Hello?
Hello, sir.
I'm grateful to you for a nice presentation. I remember that my parents used to tell me that you should go to the study, you remember the topic when you are walking. So study when you are walking. That's how you have proven this.
Hello, sir. It is not clear, sir. The question is not clear.
We were told by our parents that the students should be mobile while learning the topic. It means that they should walk when they are reading. That enhances the memory.
To a certain extent, walking is a sort of vestibular stimulation, sir.
Vestibular physiology, yes, vestibular stimulating actually enhances the learning. That's what our old knowledge is. Is it true or
Yeah,
not?
sir.
No. Okay, thank you very much for the nice presentation. Thank you. It was
Thank you.
enlightening to us. Thank you very much.
I request Dr. Shilpa Kullar to please felicitate sir. वो है।
Now, the next topic is therapeutic effect of vestibular stimulation with control stress and relief free radical generation by Dr. Smita. Dr. Smita, please present your presentation.
Good afternoon all. I myself Dr. Smita, Professor, Department of Physiology, LIMSAR, Angamari. Today's my topic is therapeutic effect of vestibular stimulation to control stress and free radical generation. This work was done under the guidance of my sir, Dr. J.K. Mukherjee.
Hello, sir. Yes, sir.
Hello.
Hello, sir.
Yeah, hello. Ma'am, we had these three names of Dr. Joseph, Dr. Devi, and Dr. Remya.
Dr. Remya. Okay, sir. Okay, sir. Okay, sir.
Yeah. So we would now just felicitate our chairperson and then we'll close the session.
Okay, sir.
I thank all the presenters and all the members who have attended today's session. And we now close the session for today. Thank you very much to everyone and meet you all tomorrow. Thank you.